Ramesh, somebody is monitoring the live also, the live feed.
Video போட்டு பார்க்கறேன்.
I am monitoring.
Okay, Ramesh. Okay, fine. Madam, I think we can start. I think.
Yeah. The chairpersons are there. Anyway, I'll just introduce.
Yeah. Chairpersons are there.
Okay. Good evening. It's indeed a pleasure to be with you all again for this webinar. And today it's going to be a very excellent webinar, I'm sure, because we are going to discuss about a very amazing organ, pancreas, which has always excited me. Because when we started, we didn't have much to talk about the pancreas. We just had 4 pages to read and one on congenital abnormalities of the pancreas. But now there are books on pancreas, and we have none other than our Dr. Amit, who will be talking, and Dr. K.R. Palniswamy will be introducing. But before that, I would like to introduce all our chairpersons, Professor K.R. Palniswamy, from the senior most here, who's done so much of work in pancreas, and Dr. Chandrasekhar. I remember he's been always interested in the pancreas. I remember him doing EUS and thing for a lady who was pregnant and had problems in the pancreas, and interesting endotherapy he used to do. Dr. Mohan Prasad from Coimbatore, his meetings on pancreas we've all attended, and we have a surgeon also, Dr. P.G. Balachandran. So we have eminent chairpersons, all very senior most and experienced and having expertise in the field of pancreas. So without wasting much time, I would just hand over this session, and I'm sure it will be beneficial to everyone who's attending. And I think this would be recorded and we can re-listen to it. And we wish you all a wonderful and a pleasant evening. Sorry, we are not able to give you bouquets, but this is our wishes to all of you. Thank you.
Good evening and welcome everybody. I'm very happy to introduce a good friend of mine, Dr. Amit Medhio, and we've been associated with him for a long time. In fact, he was the faculty for first endoscopy workshop in a government setup in 1990. And after that, Amit Medhio has been associated with us for several other meetings. And Dr. Amit Medhio is a surgeon, basically, turned endoscopist. And he is a pioneer in the field of therapeutic endoscopy in our country. And his work in ERCP is he has done a lot of path-breaking work in ERCP, developed new protocols in the treatment of pancreatic and CVD stones, and he has done pioneering work in third space endoscopy. He conducted numerous live workshops and training programs with which all the many doctors from our country were benefited, not only from our country, even overseas. And he has been an invited faculty in various international forums. And currently, Dr. Amit Medhio is the founder, director of the Baldor. And he was a former president of the Society for Gastroenterology and Endoscopy of India. And he was the recipient of the highest civilian award, that is for the Padma Shri from President of India. Without wasting much time, I would request Dr. Amit Medhio to talk on endotherapy of chronic pancreatitis. Any other other chairpersons on the topic?
No, sir. After that.
Yeah.
Should I begin?
Yeah, you can.
Okay, so first of all, I want to say that it is a great honor for me to talk to the Tamil Nadu chapter of Indian Society of Gastroenterology. And thanks to Dr. Malti and Professor K.R. Palniswamy, Dr. TSC, and all the chairpersons who are there today. The topic which was given to me was endotherapy of chronic pancreatitis. Is it better than surgery? But before I begin my talk, I just want to tell you that many years back, when I started my career, and I was trained by some famous surgeons from Mumbai, and when I was taking training from them, one of them had told me a long time back that when the question is wrong, the answer cannot be right. So here, if you see, is chronic pancreatitis endotherapy better than surgery? According to me, in today's scenario, the question itself is wrong. So the answer cannot be right. However, I'm going to take you through this series of slides and unravel the mystery of chronic pancreatitis and related role of the endoscopist in chronic pancreatitis, and what are the changing concepts in this area over the last so many years. It's very important to remember that chronic pancreatitis is not a very simple disease. And if you study patients of chronic pancreatitis, not only in our country, but in this region of the world and in various parts of the world, you will realize that chronic pancreatitis is of varied etiology. It has a varied morphology and varied methods of presentation. And if you see here, the type of patients which come to the doctor from the Western region, Western world, or the Eastern world vary considerably. And the spectrum also varies depending upon whether the etiology is alcoholic or whether it is idiopathic. Here you can see a series of ERCP pictures of patients of chronic pancreatitis. And in almost everyone, you see here a completely different pathomorphology. Well, so therefore, the treatment is not going to be simple. If you were to see the manifestation of a patient of chronic pancreatitis, they can manifest in different pathophysiologies. Either it can be a stone predominant disease, or it can be a stricture predominant disease, as you see predominantly in the West, stone predominant disease, as you see predominantly in the East, or mainly in our peri-equatorial regions. You can have a combination of stones along with strictures. You can have associated biliary strictures. You can have associated pseudocysts. And in some patients, you can have a hard gland, and they can also have a pseudomass or inflammatory mass type of appearance. Now, these type of pathomorphologies also vary in this entire spectrum, from idiopathic or what we call tropical chronic pancreatitis to alcoholic chronic pancreatitis. Well, all said and done, even today, in spite of so much of advances in endotherapy, in surgery, in laparoscopic surgery, in everything, still the indications for intervention in chronic pancreatitis still continue to be pain relief. Otherwise, it is normally considered that we should not intervene in a patient who does not have pain. Unfortunately, the modality, the cause, or the etiology of pain is still not very clear. However, it is attributed to either neuropathy, increased intraductal pressure or parenchymal pressure, pancreatic ischemia, and sometimes even acute inflammation. Just want to state that there are two evolving indications which have evolved over the past decade or so because of the advances in the endoscopic treatment of chronic pancreatitis and even good results of surgery. That is a possible improvement in the exocrine and endocrine function. So therefore, even if patients of chronic pancreatitis present to you without pain, but who have a gross exocrine endocrine function, and if they have a pathomorphology which is suitable, probably these patients are suitable candidates for intervention or therapy, because from our latest data, from our experience, from the world experience, we have noticed that around 30 to 40% of patients will show an improvement in their endocrine function, and almost 60% patients will show improvement in exocrine function if you do intervention and you relieve the ductal obstruction. Endoscopically treatable manifestations, if you ask me, are three. Number one is stone disease. Number two is strictures, which are dominant strictures, not strictures which are throughout the duct. And third, which are pseudocysts. And I will come to that, but these pseudocysts are a little bit different from what you see in acute pancreatitis. So three endoscopically treatable manifestations of chronic pancreatitis: stones, strictures, and pseudocysts. And of course, as I mentioned to you before, other indications would be the treatment for weight loss because of exocrine deficiency, and diabetes, which is because of an endocrine problem. So how do we go about it? If you see stone disease, there has been sufficient amount of literature, sufficient amount of data, which has now shown us that what actually is the cause of stones in chronic pancreatitis. Number one, it can be either a genetic or an alcohol etiology. But what is most important is in all patients who form pancreatic stones, we have found that they have increased protein content in the pancreatic juice. And if you study the pancreatic juice in patients who form stones in chronic pancreatitis, the amount of protein in their pancreatic juice is 400 times that of a normal person. So therefore, what happens is in many of these patients, because of the high protein load, the pancreatic juice becomes rather thick, and therefore there is a sluggish flow of the juice. These proteins, they form plugs and they block the duct, because of which these patients develop episodes of clinical or subclinical episodes of acute pancreatitis. And on these protein plugs, there is deposition of calcium. So the calcium goes and deposits on the protein matrix, and depending upon the amount of calcium that deposits, you either have radio-opaque stones or you may get radiolucent stones. So this is the way, basically, the pathogenesis of stone formation in chronic pancreatitis. What about stricture formation? It is now well known. There has been a hypothesis which was floated by a German pathologist almost 50 years back called Kloppel. It is called as the Kloppel's hypothesis, and he called it is the necrosis fibrosis sequence. It is what Kloppel's hypothesis, where he postulated, and this holds true even today, that, as I mentioned before, because of some reason or the other, there is clinical or subclinical acute pancreatitis, which causes an injury to the pancreatic duct. That leads to a stricture formation, sluggish flow, further episodes of acute pancreatitis, further injury, and slowly, because of this vicious cycle, the gland hardens, and that stricture can become tighter and tighter because of further fibrosis. So this is the pathogenesis of pancreatic strictures. What about pancreatic pseudocysts, which happen in chronic pancreatitis? Number one, the reason is recurrent acute pancreatitis episodes. There is ductal rupture, leakage of juice, and collection. Fortunately, in collections which occur in chronic pancreatitis, these are usually small, and invariably, collections in chronic pancreatitis are communicating with the pancreatic duct. So therefore, they are much more amenable for endotherapy than a collection which occurs due to acute pancreatitis. When a patient of chronic pancreatitis comes to you for treatment, today we have come to a conclusion, and I would like to say that it is mandatory that we do these investigations before you embark on any treatment or decide whether the patient is suitable for endotherapy or surgery. Most important is a simple X-ray or a fluoroscopy. Many of us forget to do this. So if you have a C-arm in your department, at least take the patient on the table, do a fluoroscopy. And with this, you will be immediately able to pick up whether the patient has radio-opaque stones or no. Even if the patient comes to you with a sonography or a CT scan report of stones, fluoroscopy becomes important. Because if stones are shown on a CT or on a sonography, and on fluoroscopy you don't see them, that means these stones do not contain so much calcium. They are radiolucent stones. So therefore, these stones can be taken out quite easily if the duct morphology suits endotherapy approach. Second important test to be done, any patient of chronic pancreatitis is an MRCP. MRCP today is the gold standard, because with this you can study the ductal anatomy. You will come to know whether there is associated stricture, whether there are pseudocysts, whether there is a complex disease, whether there is a SOL. And if you do find that there could be a complex disease or an SOL, you have to follow it up by doing an endoscopic ultrasonography or even a CT scan. EUS can also be associated with the EUS guided FNAC if there is a mass-like appearance which is seen in the ductal morphology. Well, once you have done a fluoroscopy, and you can either the stones can be radio-opaque or radiolucent. You can see here 20 to 60% of patients of chronic pancreatitis form stones. So therefore, stone disease is the predominant pathomorphology in chronic pancreatitis. These stones can be radio-opaque or they can be radiolucent, and you can pick them up immediately as soon as you do a fluoroscopy. The different or the characteristics of stones occurring in the pancreas is funny, because you see here, they are not as simple as bile duct stones. And single or multiple radio-opaque stones are seen in 90% of the patients who come to us in India. Only 10 or 15% of patients have radiolucent stones. They cannot be seen on fluoroscopy. And the characteristics of pancreatic stones is, as against bile duct stones, is they are not only hard, but they are spiculated, almost like the coronavirus. They are impacted in the pancreatic ductal epithelium. They are usually associated with pancreatic ductal strictures or complex pathologies. And sometimes these stones are inaccessible. Only in around 10 to 15%, you have stones which are radiolucent. So in case you do have a patient who has radiolucent stones with a dilated duct, as we quite commonly see in our country, endotherapy is extremely effective. And as you can see here, when we do an ERCP and we opacify the pancreatic duct, you can actually see that the duct is full of big, big stones. In fact, one will feel that how are we going to take out these stones by simple endotherapy, whether this patient is going to need surgery. However, endoscopic techniques have now evolved very well, and we are applying the techniques which we use for bile duct stone removal. For example, we go ahead and first perform a pancreatic sphincterotomy. You see here, pancreatic sphincterotomy is usually performed at 12 o'clock to 2 o'clock direction. It is not done at 11 o'clock direction as we normally do a biliary sphincterotomy. Then, in patients who have got a dilated duct with radiolucent stones, which are not seen on fluoroscopy, we can easily do a balloon dilation of the pancreatic sphincter. As against a bile duct balloon sphincteroplasty, in pancreas, we do a CRE dilation only up to 12 mm. We usually do not exceed 12 mm CRE dilatation. And after we have dilated the pancreatic sphincter, by using a simple balloon extractor, even if the entire duct is full of big stones, which are radiolucent, you can achieve a complete ductal clearance, sometimes even in a single sitting of ERCP. In case you feel that the ductal clearance is not adequate, then what we do is we temporarily place a pancreatic ductal stent, either a 5 French or a 7 French stent, call the patient back after 3 months, repeat the ERCP, complete the ductal clearance totally, and then leave the patient on a total stent-free trial. So this way, we can achieve a complete ductal clearance with endotherapy in those patients who have a suitable pancreatic ductal anatomy and radiolucent stones. As I mentioned to you, radio-opaque stones are a little different. They're not as easy to remove as radiolucent stones. However, you may be lucky. You may get a patient who has a radiolucent stone, but the duct is dilated. There is just a single stone like this floating inside the duct. Now, these patients can be treated very well by use of a simple basket. You may not even need to do a balloon sphincteroplasty as you saw on the previous video. So once again, we go ahead and do a pancreatic sphincterotomy towards the 2 o'clock position. Use a simple Dormia basket. Either it can be a simple Dormia basket, or we can use a wire-guided Dormia basket. Put the basket till the tail of the pancreas, open the basket, and almost like fishing, you just pull the open basket down and you can take out radio-opaque stones provided they are small. But this is not the case in most of the times. In many cases, patients whom we get in India, we get pictures like this, where the duct is dilated and they may have stones spread out in the duct. They may have only located in the head or in the mid-body, sometimes in the tail. And in these patients, it is mandatory before you perform an ERCP that we have to pulverize these stones into powder. And this is done by the technique of shockwave lithotripsy, or ESWL. With the latest generation shockwave lithotripters which we have, it not only has an increased accuracy, increased efficacy, but increased safety. If you use simple lithotripter, which is used in kidney for kidney stones, sometimes the shock waves can get dissipated and you may not be breaking the stones sufficiently, and the stones may not pulverize. In fact, you can cause damage to the surrounding organs, including kidney, and the patients may have lot of duodenal contusion, intestinal contusions, and they may also present with hematuria. So what we do in these patients is, if you have a suitable anatomy, even if the stones are radio opaque, don't do an ERCP, don't place a stent, don't place a nasopancreatic catheter, subject the patients to ESWL. How do we perform ESWL? We usually use a special type of a machine which has got a very narrow focal point of only 5 millimeters. Patient is kept in a supine or a semi-supine position. The stones are localized by fluoroscopy in 2 axes. It's important that you have a ESWL machine which has got an integrated C-arm. You should not have a machine where you attach the C-arm from outside, because if you attach the C-arm from outside and it is not integrated, the localization is not proper and your shock waves will diffuse. While doing ESWL, patient is likely to have pain. So either you can have a propofol or a intravenous, total intravenous analgesia or anesthesia. Sometimes we can also use epidural anesthesia. Of course, these patients have to be monitored by pulse oximetry, NIBP. The bellow containing the water of the machine comes in close contact with the anterior abdominal wall all by the side. And then we start delivering the shock waves with low amplitude first, level 3. And we keep on delivering waves. 5 to 10,000 shocks are given per session. And you can give 2 or 3 sessions like that on alternate days. So usually we maintain an alternate day schedule. Patient does not need to be admitted. Patient can be sent home. Patient is called back. And the end point of ESWL is very important. The end point of ESWL is pulverization, not fragmentation. So we have to fragment or pulverize the stones till they become less than 3 millimeter fragments. So you see here, how do you know that your ESWL is proper? You see here, these are the stones before. And here you see this. This is in German language called as a Steinstrasse appearance. That means a road which is full of stones. So the stones spread all along the duct. You can see here the fragments, the multiple pulverization, the powder is there of the stones. Only when you achieve this, then you can go ahead and perform a ERCP and do a ERCP for extraction. So how do you know that the ESWL is effective? Loss of density, spreading along the duct, and sometimes if there is a single stone, the stone can even disappear. So you may have a single stone in the duct, and endotherapy or ESWL can even serve as a monotherapy in these patients. After you have performed ESWL, then we go ahead and do a ERCP. This is done in the same way. We opacify the duct. These are all pulverized stones now. So we go ahead and now we are doing a cutting of the sphincter. You can see that the whitish pancreatic juice is coming out along with some of the stones. And then we once again use a balloon. And once we sweep the balloon, you can see the pulverized stones which are coming out. Many times when we do ERCP in these patients, some stones do remain inside. In fact, some stones are stuck on the wall of the duct. So therefore, it is better, instead of just keep on attempting the balloon extraction, either we can place a 5 French stent, 7 French stent, call the patient back after a couple of months, repeat the ERCP, and before doing ERCP, once again do a fluoroscopy. If you find some more radiopaque stones, do a repeat ESWL, then take them for ERCP, and then complete the therapy, and by which we can totally clear the duct of all its stones. All this is provided that the ductal morphology is suitable. If the patient has multiple strictures along with stones, it is not as simple as I showed you in the video. Therefore, we have to dilate the strictures first. We have to place multiple stents. We have to pulverize the stones, keep on dilating the stricture, and then attempt endotherapy. Sometimes we find that the stones are so much impacted that our wire does not go through. So then in such a situation, we use a US-guided rendezvous approach. You see here, under endosono guidance, we can locate the pancreatic duct through the stomach, posterior wall of the stomach. We puncture it with a 19-gauge needle. Then we opacify the pancreatic duct through the body or through the tail. And once the needle is inside, properly in the duct, we can place a wire through the 19-gauge needle and get it across the ampulla obvator, and then pass the ERCP scope, catch the wire, pull the wire up through the channel, and then over that we can pass our instruments and complete the therapy. So in patients where you are failing cannulation through the main papilla or the minor papilla because of an impacted stone, impacted powder, you can attempt an US-guided rendezvous approach, and by this you can achieve a cannulation. In fact, nowadays with the advent of cholangioscopy, we have started using the same spyglass cholangioscope for the pancreas, and we have started doing pancreatic endotherapy in some patients who don't respond to ESWL. For example, you see here radiopaque stones in the pancreatic head. They have not responded to ESWL, and the stones are not getting pulverized, but we need to remove them. So we perform a pancreatic sphincterotomy, do a little dilation with a balloon, and then after doing a balloon dilation of the pancreatic sphincter, we pass the spyglass inside the pancreatic duct. You see here, and even if the stones are located in the head, we can directly see the stone, and usually these stones can be pulverized quite well by using the laser, holmium laser. However, once again for this, our spyglass has to reach the stone. If the stone is located behind a stricture, this procedure is likely to fail. So stricture and stone combination is a bad combination, and if you find that, then you usually have to resort to stenting protocol, make the stricture dilated, allow your instruments to go in properly, and then perform a ESWL, pulverize the stones, and then start taking out the stones. So therefore, a combination of modalities is required. What about those patients who present with stricture predominant disease? I just want to tell you, it's not as simple, because various types of strictures you can find, and this you can pick up on MRCP itself. You can have a single stricture, multiple strictures, tight strictures, soft strictures, complex strictures. And this can be the pathomorphology in chronic pancreatitis. And that is exactly the reason why in those patients who have an alcohol etiology, usually they have stricture predominant disease, they have complex ductal disease, and therefore the results of endotherapy are usually dismal. However, in spite of all that, if you have a stricture which is just a single or maybe two strictures, then the common protocol which is now practiced all over the world is what was published in 2014 in the ESG guidelines, is as soon as possible you should try to place a stent of at least 10 French. If you can't place a 10 French stent in the beginning, at least place a 7 French or a 5 French, call the patient back soon, try to upgrade it to a 7 French, then place a 10 French, and then leave the 10 French stent inside for at least 6 months to 1 year. After 1 year, when you take out the stent, if the stricture has opened up, if it has resolved, you can leave the patient alone if the patient does not have stones. But if the stricture is persistent, then the patient should be given a chance to decide whether the patient wants to go for a surgical consult. If not, then we can persist for endotherapy, and endotherapy will now consist of placing multiple stents to treat that stricture. So what we do is, in these patients, we place multiple stents of 10 French and place 2 or 3 10 French stents, leave those stents inside for another 1 year. In spite of that, if the stricture does not resolve, we should not persist with endoscopic treatment. I know that nowadays expandable metallic stents have come, and for single dominant tight strictures in the pancreas, even if you can't dilate them, sometimes we use a corkscrew device or Sohendra stent retriever device. We can also use what we call as a cystotome for cutting the stricture. We can use a cystotome over wire, cut the stricture, be able to place a stent, upgrade the stent after 3 months, 2 10 French stents, or maybe slowly 2 7 French, then 1 10 and 1 7, and then 2 10, leave it for 1 year. After 1 year, if it does not respond, these patients should be sent for surgery instead of trying to persist with endotherapy and then later on sending the patient too late for surgical. Here you see we are used, for example, if you have a very tight stricture, we can use the Sohendra corkscrew device, which is called as a stent retriever. This was a patient who had a pancreas divisum. Here you see here that we are now cannulating the minor papilla. We go inside, do a sphincterotomy of the minor papilla. Because the dilator did not go through, we pass a 10 French Sohendra stent retriever. We pass inside, and by rotating the screw type of device, we can dilate even a very tight pancreatic ductal stricture. However, I feel that better that this device is a cystotome, because it causes lesser damage to the pancreatic ductal epithelium. And instead of using a Sohendra stent retriever, we can use the cystotome. This is a fully covered expandable stent. The bumpy stent was invented. It was launched by a few companies many years back. We have used it on a few occasions. In some patients, the results are quite good. The problem is, because of the design of this stent, even if the stricture resolves, at the end of the stent, because of the flanges which impinge inside the pancreatic duct, new strictures are likely to form because of the stent itself. Of course, the initial trials with expandable metallic stents have shown good results, but in whichever patients we have used them, we have found that expandable metallic stents can cause sometimes trouble because they can migrate, they can spontaneously go out and cause trouble. Pseudocyst in chronic pancreatitis, less than 9% spontaneously resolve as against acute pancreatitis. But the good part is almost 60% have ductal communication. So therefore, in pseudocysts which form in chronic pancreatitis, transpapillary stenting is the first line of treatment, recommended, grade A. You see here, because these pseudocysts are in communication with the pancreatic duct, if you drain the main duct, these pseudocysts usually will drain out and they will slowly resolve over a period of time. So the message which I want to convey is chronic pancreatitis is not so simple. I again mentioned to you that it has varied etiology, varied morphology, and varied manifestations, varying from tropical pancreatitis to idiopathic pancreatitis. And most of the literature which has been published on the pathogenesis of chronic pancreatitis in the world today, if you study it very carefully, you'll realize that alcoholic pancreatitis and idiopathic or tropical pancreatitis are actually two ends of the same spectrum. Because if you were to see, alcoholic pancreatitis is not due to alcohol alone. There are so many alcoholic patients who never develop chronic pancreatitis. Whereas tropical pancreatitis is not due to genes alone. Because if you study genetic mutation in patients of tropical pancreatitis, you will find mutation in only around 40 to 60%. What about the remaining 40% or 50% who do not have genetic mutation? So therefore, what is the cause of chronic pancreatitis in these patients? So you see here, the new insights in pathogenesis of chronic pancreatitis is TIGAR-O hypothesis, is these patients of chronic pancreatitis have a defective protective factors. So what happens is, because of defective protective factors, even any sentinel episode of acute pancreatitis, which can be because of alcohol, biliary, viral, environmental toxins, drugs, divisum, metabolic, obstructive, they keep on developing clinical and subclinical episodes of acute pancreatitis, necrosis of acinar tissue, activation of pancreatic stellate cells, fibrosis, and then a full-blown chronic pancreatitis. So what is most important is defective protective factors. And you see here, 4 genes are attributed, or they have been as culprits which can lead to this defective protective factors. First is the SPINK1. Everyone knows only about SPINK1 gene. SPINK1 gene you see here is responsible for maintaining the integrity and regeneration of acinar cells. CFTR gene, you see here, regulates the pancreatic duct secretion, and it has the ability to flush the activated trypsin. Whereas CTSB or cathepsin B gene regulates the intracellular pH and the calcium levels. Whereas the REG1 gene, REG-A1A gene, it prevents pancreatic lithiasis by inhibiting crystal nucleation in the juice. So therefore, if there is a mutation in any of these 4 genes, the protective mechanism in these patients is lost. So therefore, these patients become more prone. So changing insight today is what? In peri-equatorial countries like India, you have the same in Sri Lanka, the same in Bangladesh, the same in some African countries. They have what we call as subclinical pancreatopathy. That means the pancreatic juice in all these patients is low in enzymes, high in calcium and protein, and high in lactoferrin. And the gland is vulnerable to injury. So therefore, second or multiple hits can lead to chronic pancreatitis, whether it be because of diet, environmental toxins, alcohol, smoking, etc., etc. In addition to the 4 genes which I showed you before, 10 new protective genes are still now being studied. And therefore, there is basically, I have a feeling that all chronic pancreatitis, I think, is genetic in its etiology. In addition to that, all these factors play a role. This is exactly the situation. Now, why are the results of endotherapy not uniform all over the world, all over the country? The main reason is people have not understood which patient to treat, how to treat, and there is a wide variation in etiology and pathomorphology. Most of the controlled clinical studies which have come in the world, randomized control studies, have been published in the West, where they see predominantly alcoholic etiology patients. Pathomorphology is completely different. You cannot compare endotherapy with surgery in those patients. Unclear selection criteria. The criteria for selection for endotherapy have to be proper. Then availability and experience with ESWL. You must have realized from my talk that if you do not have ESWL, a good machine available with you, treating radiopaque stones is not worthwhile by endotherapy, because the first step of endotherapy is ESWL. Then arbitrary stenting regime. Many of the endoscopists still do not know which stent to place, how long to place, what type of diameter, what should be the characteristic, whether there should be flaps, how many holes, whether it should be pigtail or non-pigtail, whether it should be 5 French, 7 French, 10 French, and how long to keep it. And so therefore, undefined endpoints of therapy. See, when you embark on endotherapy of chronic pancreatitis, in your mind, you should have defined endpoints. For example, ESWL, you should know whether ESWL has worked, whether you have pulverized the stone, whether you have done stenting. There has to be some endpoint. You can't keep on putting stents permanently. So if you have these criteria proper, then you can select these patients properly. So therefore, coming back, this spectrum from west to the east, alcoholic, idiopathic, and tropical. If you ask me personally, in today's scenario, if you have this type of a pathomorphology, these patients should directly go for surgery. Alcoholic etiology, stricture predominant disease, and complex morphology. as an endoscopist, we should not even try to attempt endotherapy. Or if patients who have small duct disease, you keep on placing stents, your stents are doing much more harm than benefit. The patient keep on coming back to you with pain, and you keep on changing the stents. All that the patient does is spend money. But if you have patients who have a dilated duct, even if they have stones spread all over the duct, whether it is radiopaque or radiolucent, depends upon whether you have an ESWL facility. I think these patients are eminently suitable for endoscopic therapy. So that's the end of my talk. Thanks for your attention.
Thank you, Dr. Amit, for the excellent talk. I think there are a lot of questions, burning questions will be there. And I would like to ask you, the patient, case of chronic pancreatitis has had a lateral pancreaticogestomy. In spite of surgery, sometimes they continue to have the pain. For the duct is dilated, no stones. What will be the approach in such a case?
Well, in such a case, you should offer them endotherapy, because then what we can do is we can go from the ampulla of Bator, we do a pancreatic sphincterotomy. If required, dilate the balloon with a balloon, the pancreatic sphincter, and then we place a stent throughout the dilated pancreatic duct coming from the duodenum and going into the jejunum, where they have done a pancreaticojejunostomy. And the stent has multiple holes. So now we are draining the pancreatic duct completely. We get these patients quite often. In fact, some of these patients have developed some stones also. If they have developed stones, then we shoot the stones, pulverize them, and then perform endotherapy.
Thank you. Any other questions? Any comments from the other chairpersons?
Can I just intervene as a surgeon?
Yes.
Dr. Painisamy, your question was that a patient of pancreaticojejunostomy comes with a pain.
Yes.
We should remember that as many of these patients who undergo pancreaticojejunostomy, the stoma of pancreatic duct and the jejunum is like a chicken-hearted stoma, what we say.
Okay.
What we usually, a surgeon recommends is you should be a longitudinal pancreaticojejunostomy. As much as possible, you do it. But most of the patients whom I have done a revision pancreaticojejunostomy, I found that they have done a very limited 1 or 2 centimeters, especially by laparoscopic surgeons. Actually, if you just see, you have the principle of doing a pancreaticojejunostomy is you have to completely cut the entire pancreatic right from the head up to the tail.
Okay.
So most of these patients who undergo the pancreaticojejunostomy surgery, they do not undergo properly actually. That is one of the reasons they come with when it is undrained ducts, they come with a pain.
Can I ask a question, sir? Professor KRP, sir?
Yes.
Okay. Just enjoyed Amit's lecture as usual. He's out of the way, out of the world. Congratulations for a wonderful lecture. And you're a great demonstrator as well as a speaker. I have a question to Dr. Balachandra, sir, and also to Amit. So what is the smallest duct size that you will accept for a lateral pancreaticojejunostomy? Is it 7 millimeters or 1 centimeter? You need a 1 centimeter? See, when people are doing microscopic surgeries in other fields, why are not the pancreatic surgeons, why can't they just anastomose with a microscopic surgery, even smaller ducts?
Actually, the pancreatic duct, they are divided into small duct disease and large duct disease. What is the definition of a small duct? A small duct is one. The smallest diameter is 4 millimeters, 4 to 5. And there is an excellent paper written by Dr. H. Ramesh, where he has performed a good amount of lateral pancreaticojejunostomy in a small duct disease. And he found these patients were pain-free. So a small duct disease, surgery is recommended, provided you are experienced in doing how to do it.
Can I have comments from Amit on that small duct disease? Because the US does not believe in surgery in the small duct disease. Like they don't operate lateral pancreaticojejunostomy. So what is your comment on this?
I'll tell you one thing, that from last 30 years experience of small duct disease and large duct disease and everything, that probably we may not have that quality surgeons in Mumbai or in Maharashtra, but I have found that patients of small duct disease don't do well either with endotherapy, neither with surgery. And we have found that they continue to have pain. And endotherapy, definitely no. Because whenever we have attempted endotherapy in these patients of small duct disease, we have found terrible results. Because all that the patient does is keeps on coming back with pain. And you don't know whether the stent is causing the pain or the disease is causing the pain or what's happening. And you finally take out the stent and you just tell the patient that we can't do anything. And sometimes you have referred these patients to surgeons. Some surgeons operate, some don't operate. As told by Dr. Bala, I think it depends upon the surgeon's experience of operating on small duct disease.
I think there are many questions in the chat box. Dr. Rubal or Dr. Palnisamy can take it. Can I read the question?
Yeah, you can go ahead with the questions.
I think it should be a rapid fire. There's a question from Chennai Karthik. What are the chances of disintegration of the stent within the pancreatic duct on long-term placement, Dr. Amit?
That entirely depends upon the type of stent you are using and depends upon the material of the stent. See, because stents, as I told you, are made from various designs, various materials. And nowadays, a lot of companies are manufacturing stents. There are some Indian companies who are also making stents of inferior grade material. And these stents can easily disintegrate. And you can have fragments of stents left inside the pancreatic duct.
Okay.
And therefore, it becomes impossible to take out. So choose your stent properly. Choose it from a reliable company. The material has to be very good. And it has to be tested. Otherwise, there's no point in placing that stent in the pancreas.
I think Kannan surgeon, he feels that I have seen pancreatic duct grossly infected when they come for surgery after endotherapy. I think he's angry with someone. How do you manage pancreatic duct grossly infected when they come for surgery? What could be the reasons you would like to know?
The question is to me or to Dr. Bala? Is it to me?
The surgeon is asking. I think
I do it to the endoscopist. So once again, this is a completely technical related issue.
Yes.
Number one, if you have injected contrast in the pancreatic duct, you have to make sure that the contrast has drained off properly. Otherwise, that's a source of infection. Number two, make sure that your stent length is proper, stent diameter is proper, the number of holes, the placement of holes is proper, so that the stent does not cause more complications rather than benefit. So the stent should cause benefit, not lead to complications.
Yes.
So these are all technical issues. And that's why pancreatic endotherapy is not simple. See, I'll tell you something. Even when we are doing endotherapy, the guide wire which we use, sometimes the assistant is too enthusiastic. And if he manipulates the guide wire too enthusiastically, you can perforate and you can make punctures in the secondary branches. That makes the pancreatic juice to leak out. There will be a collection that will get infected. So every maneuver, everything has to be done extremely gently, even if you're treating chronic pancreatitis. And if you do that, use the proper instruments, proper accessories, you can avoid these complications.
I think there's another question. Dhruvin Shah has asked, any relation between success of endotherapy and duration of chronic pancreatitis, Dr. Amit?
No, I don't think there is any relation. It entirely depends upon, the success depends upon pathomorphology. And if you have done your homework properly, a proper MRCP, if required EUS and CT, and you have ruled out complex ductal disease, and if it is endotherapy suitable, the success will be high. But if you just choose any arbitrary patient, then the success will not be high. ITSC.
A removal of asymptomatic pancreatic stones, do you feel they will definitely prevent diabetes mellitus later on in life? Because I think Mayo Clinic are a little different in this thought.
Because Mayo Clinic is seeing alcoholic etiology.
Okay. So,
and we are seeing a different pathology, pathomorphology. And we have found at least a 40% improvement in exocrine and endocrine function.
I think that's very good. And I think it's a very good teaching point. Kanagavel from Chennai has asked, is there any role of endoscopic sequential balloon structuroplasty in the PD? Sequential balloon structuroplasty.
No role. Because pancreatic strictures are extremely tight and fibrotic. Only balloon structuroplasty is not sufficient. It requires a continuous dilatation. So continuous dilatation can be achieved only with a stent, in increasing the diameter of stents or number of stents.
I think role of pancreatic enzyme replacement in large duct disease, I think may not be a part of this discussion, but question has come all the way from Delhi. So probably Sanchit Singh would like you to just comment on that, sir.
we usually
Yeah.
give pancreatic enzyme replacement.
And many of them have said it's an excellent presentation. And there is one more indication for intervention in asymptomatic biliary stricture. I don't know why he wanted that. Maybe it is part of chronic pancreatitis, a biliary stricture. If you feel, do you think we have to put a stent in that?
It depends upon the meaning of asymptomatic. The patient may not be clinically symptomatic, but the liver function test could be deranged. And if the LFT is deranged, if the duct is dilated, if there is a stricture, it needs treatment.
When will you refer patient directly to surgery without endotherapy? I think you've answered the question in your last slide, but I think maybe they missed it or something. Rajesh from Salem has asked that question.
Small duct disease, complex ductal strictures, inflammatory head mass, associated biliary stricture are all directly going for surgery. They are not suitable candidates for endotherapy.
Dr. Malti, there's another question from Karthik.
Yes, you can ask. Yeah.
This is despite the high migration state in the PD, usually wrote for the stems in PD, pancreatic duct. The high migration of pancreatic duct, the pancreatic stem, is any role for stems?
If you ask me personally, there are some studies which have shown good results with SEMS, fully covered expandable stents. However, it is not up to the level that it can be recommended routinely in clinical practice. So I do not think that SEMS should be as a routine first level clinical practice to be placed for pancreatic ductal strictures. You should place plastic stent.
Dr. Amit,
Yes, yes.
an excellent talk as usual. We have listened to his master's voice on chronic pancreatitis. The subject is very close to your heart. I have a couple of comments to make it.
Yeah.
In my opinion, the best indication in chronic pancreatitis, where very rewarding, is pancreatic ductal leak and fistula and pancreas ascites, where surgeon would be very pleased to hand over such cases. So I want to reiterate here is, if I get a patient of pancreatic ductal leak and pancreas ascites, that would be it's a delight for a endotherapy person. The second thing is I've come across, as you said, a pancreatic ductal stricture after bumpy stent placement. I really could not figure out why he developed a stricture beyond the stent point.
Because of the flange.
And I had to give up that the procedure. I have not been doing now bumpy stent in pancreatic ductal stricture. The questions to you is, when do you recommend minor papilla cannulation? And I'll finish off 3 questions so that you can take up. You said can be some improvement in endocrine exocrine function. How reliable it is? Because still the opinion is divided. Even because many patients ask us after the endotherapy whether my diabetic will improve or I can reduce the pancreatic enzyme, which is a very difficult answer, I said. The third one is the title itself, as complex as the subject, the topic itself is. The title is endotherapy, because TGB is watching me, Kannan is also watching me. Surgery is better than endotherapy or endotherapy. I think you made it very clear that if you choose appropriately, it's a complementary to each other. But I want to draw the attention of the surgeon here. If I keep trying all cases endotherapy, that's a failure. If you keep trying surgery for all cases, that is a failure. And NEJM, that controversial paper, in my opinion, came very small number of group of patients they have taken. And whoever reports, if the endoscopy reports, there's a bias there. If the surgeon reports, there is a bias is there. And when the surgeon report, they take the very complex endotherapy cases where they have failed it and they compare it. And when the endoscopy report, they take a very complex surgical cases, they report. But one thing is very clear, for long-term results of pain relief, surgery is better than endotherapy. With this, I just want to have your opinion, Amit. Exocrine function, endocrine function, minor papilla, and long-term results.
Okay, minor papilla is the first question I'll tell you. When do you approach through minor papilla? Number one is we approach through minor papilla if you can't approach through major papilla and if there is a persistent duct of Santorini. So that means what we call as incomplete pancreas divisum. That means there is some duct which is connected to the minor papilla, but from major you can't enter. Then you approach through minor. Sometimes there are stones also in the duct leading to the minor papilla and stones in the duct of the major papilla. So then you have to approach both the papillas, major as well as minor. And third, of course, if patients have complete divisum. Patient of complete divisum, you have to approach through the minor papilla. So these are the three criteria. Now, regarding endocrine, exocrine function, I'll tell you what I tell the patients. I never tell them that this is 100% relief or improvement of exocrine endocrine function. Because we have found from our experience and from surgical data, it has been shown that there is improvement of endocrine, exocrine function from the research papers of Neelan, who did lateral pancreaticojejunostomy. And we found exactly the same results in our data, that when we did a proper ductal clearance, there was an improvement in exocrine in almost 60%, endocrine in almost 25 to 30%. So what I normally tell the patients is, it is unreliable. We do not know whether your pancreas will respond, but there is a 20 to 40% chance that there is some improvement. And patients usually accept. Patients say, oh, if there is 20% chance, I want to take that chance. I want to go ahead. And your third question was, what was it, TSC?
Long-term versus short-term results, where the surgeon will embark on long-term results are better with the surgical.
See, I think, as you rightly said and put it, alcoholic etiology, 80% of patients are more suitable for surgery than endotherapy. In tropical pancreatitis, 60% patients are more suitable for endotherapy than surgery.
We are dealing more with the tropical.
Yeah, and we are dealing more tropical. So I think we should attempt, and we should at least select patients properly. See, as endoscopists, we should not be dogmatic. I very clearly showed you how to assess the patient beforehand. And if you have a proper pathomorphological mapping, beforehand you can say whether you are going to succeed or no. Unnecessary, there's no point in trying and putting stents.
Amit, I have one final question to you.
Yeah.
What do you enjoy in life? Is it doing pancreatic endotherapy or doing yoga, meditation, pranayam as you were doing for 60 days? Please tell us.
60 days before, I used to enjoy pancreatic endotherapy. But today I enjoy yoga, meditation and pranayam.
Wow.
I think there are just four more questions in the chat box, Dr. Amit. One is risk of pancreatitis after endotherapy, how to prevent. From Surat, Dr. Smith has asked.
Well, in chronic pancreatitis, usually these patients don't develop acute pancreatitis after endotherapy because the pancreatic gland takes your intervention quite easily. However, in spite of that, we give these patients a diclofenac just before starting the ERCP. And after the procedure, we usually keep these patients on a liquid diet for a week. If you have done major endotherapy and major manipulation.
Kanagavel from Chennai again has asked, sir, how far are we from endoscopic pancreaticoenterostomy for chronic pancreatitis? How far are we from that?
Oh, we are almost doing that now. We are doing EUS-guided pancreaticogastrostomy. So if we have a tight pancreatic stricture, and if you can't go from the main papilla, what we are doing is EUS-guided. We are puncturing the pancreatic ductal, dilated duct, and we are putting a stent and then converting it to a metal stent. We can place a metal stent joining the pancreas to the stomach. So we are performing a pancreaticogastrostomy. I am not very sure whether this is the right physiological approach from the surgical standpoint. However, we have found the patients become asymptomatic after doing this procedure.
Tirumal from Coimbatore, role of pancreatic sphincterotomy in idiopathic recurrent pancreatitis.
Means what? I mean, idiopathic recurrent pancreatitis, but depends upon the morphology. If the duct is dilated and if the duct is containing some stones or maybe sludge or even pancreatic stone protein, you can perform a sphincterotomy, clear the duct, leave a 5 French stent only temporarily, and then take out the stent as fast as possible. Because one thing you have to remember in pancreas, don't leave unnecessary foreign bodies in the pancreas for long time. So unnecessary stenting should be avoided. If at all you place stents, they should be temporary.
Amit, I think he's meaning recurrent acute pancreatitis, probably because of the biliary microlithiasis, doing an ERCP and a sphincterotomy.
No.
Biliary sphincterotomy.
Biliary sphincterotomy. But just pancreatic sphincterotomy is of no benefit in these patients.
Kannan, from a surgeon from Chennai, I know he wants head mask, how to manage. He's handing that also over to the endoscopist.
What?
Head mask.
Head mask.
Phlegmon.
In head mask.
Phlegmon. But no word, we don't use that. Head mask is written.
Phlegmon.
Dr. Kannan, you can speak, you can unmute and talk.
No. I think what Kannan is asking is the mass in the head, which is an inflammatory mass, versus a malignant mass, how to probably manage or differentiate.
I'll tell you what.
Phlegmon. 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 Phlegmon.
So I do not know whether there is any terminology like that now in
That
chronic
is now
pancreatitis.
gone, yeah.
But inflammatory mass in the head, we will assess with endoscopic sonography. However, I will tell you that EUS is not a very specific test to know or differentiate malignancy in a inflammatory head mass in the setting of chronic pancreatitis. The success rate of achieving a diagnosis is very low. But if you are highly suspicious of a mass, the patient should be sent to a surgeon. And I'm quite sure the surgeons will be happy to do a head coring procedure or something like that in such a case.
Yeah, in fact, I wanted to just talk about this. In our country, more than 80% of the patients of chronic pancreatitis come with a head mass. And in such patients, we not only completely do a removal of that is, we do a coring of the head. That's called Fraise procedure, wherein we do a nice head coring, go up to the uncinate process, empty all the stones, open up the entire pancreatic duct, do a pancreatitis. Another controversial question about Dr. T. Chandrasekhar regarding diabetes. We know chronic pancreatitis, 1/3 of the patients, they already have diabetes. The remaining patients, when you operate or do endotherapy, whether there is an improvement of this diabetes, there is a lot of controversy. But what is stated in the literature is the patient after such procedures will not deteriorate. His diabetic status will not deteriorate further. Suppose if you do not operate or do endotherapy, he may go for endocrine, exocrine insufficiency. But you intervene and do the endotherapy or surgery and decompress the duct, there will not be deterioration of the further of the diabetic status.
That point is agreed, Dr. GB. Whether the surgeon or endoscopist will take the credit only, I am asking. One thing very important is who does the procedure, who does the endotherapy, who does the surgery. I'll tell you one example where if the patient has undergone surgery, comes back 6 months later with the pain. Then we found out they have done the pancreaticojejunostomy in the body and the tail region. Head they safely could not do for some reason or other. So we had to do the revision surgery. Head coring had to be done. Same is true with the endotherapy also. As Amit nicely pointed out, there should not be even one foreign body, in the meaning that the stone or stricture, the stent should not be there. So what is most important is the completion of the procedure. The experience and expertise matters. Otherwise, endotherapy may fail and surgeon will take the credit. The surgery may fail and endotherapist will blame.
Whatever
so I think
we do,
most important training.
Whatever we do, TSC, as endoscopist, I want to give a message that you should have clearly defined endpoints. And if you do not have clearly defined endpoints and proper selection of patient, whatever you do is going to fail. Because
so
chronic pancreatitis...
Where we need to end, where the surgeon should start, or where the surgeon should end and endoscopist should start.
Yeah. For example, I'll tell you what, if you have a stone disease, your endpoint has to be stone clearance, not just placing stents. If you have a stricture, your endpoint has to be stricture resolution. And if you can't achieve that in 3 years, better send the patient to a surgeon.
The most difficult thing is head mass in the pancreas, in a chronic pancreatitis. If I have a clue like duodenal infiltration or CA99 is grossly elevated and pointing more towards malignancy, and a quick observation for 1 or 2 months or the FNAC might help us. That is a very, if you are in doubt, better to hand it over to surgeon. And whether it is a malignancy, we are happy that you have done the surgery. If it is a benign also, you have taken the lead, you have done that for the head coring.
So we work very closely with our surgeons in Mumbai. And therefore, our surgeons have faith in us, we have faith in them. So it is like a very nice team. And unnecessarily, they will not do a pancreaticojejunostomy if the patient is suitable for endotherapy.
Chennai is also as good as Mumbai.
But Amit, you don't need any surgical opinion. You yourself is a surgeon. Today I enjoyed your talk because it was absolutely unbiased, your talk.
Thank you.
You were I was really enjoying your talk as a surgeon. You are really called as a surgical endoscopist.
But I hope the endoscopist also enjoyed my talk.
So you are a surgeon plus an endoscopist. So your absolute designation is changed completely. And today you have brought out excellent points, and you are very impartial. And so it has come up from a horse's mouth, I would say. Thank you.
Thank you, Dr. Amit. Excellent talk.
Thank you.
Dr. Panisamy, you can give your final word.
Thank you once again, Dr. Amit. It was an excellent talk. As always, all your talks have been excellent. This is really super. Thank you very much.
Thank you so much.
Thank you so much. Thank
Bye.
you.
It's a
Bye.
great honor and privilege. Thank you. Bye.
Thank you, sir.
Paul,
Yes, sir. Sir, you please stay because we will be continuing with the other three presentation.
I will
So
stay
all
now.
the, all the chairpersons, please stay because
Overall
we need you.
chairperson, me and
Yourself, KRP, and
TSC, you have got endotherapy now.
Bala sir and Montsan sir. Before starting Vishnu, I'll briefly tell
So
the
you have a
secretary
tea
report.
break now?
You can have a tea break, sir. Yeah, absolutely. So because I briefly tell what has happened in the last few months, and our TNAG IBD study, which was started in June 1st. So far, we have registered 270 plus cases within a month, and almost 19 centers started enrolling, and another 13 centers yet to start because some of the government centers, they are busy with the COVID work, and maybe they'll start enrolling. So we are planning to end the study by the end of December, and hopefully our target will be more than 1,500 plus cases, and hopefully we'll reach that number. The other two large-scale studies we are contemplating is one is alcoholic liver disease, which is and the performance is getting ready. It was coordinated. It will be coordinated by Shanti Vijayaravan, L. Venkatakrishnan, and Prem Kumar. Maybe another 2-3 weeks, the performer will be ready. The second large-scale study will be the profile of GA and liver cancer, which will be carried out by Dr. Eapen and team. Again, the most likely we'll similar to IBD study, we will work through our website. That will be easier to control and assess. These are the three projects I think probably we will aim at to start in this current year. And the other thing is our last two webinars, whoever missed it, which is available in our website. So you can, whoever missed it, you can go through that. Another important aspect is we are very much excited is starting our journal that is called Gastroenterology, Hepatology and Endoscopy Practice. It is GHEP. And the groundwork were finalized, and we identified the publisher, and we had an initial payment that was done. And the editor-in-chief will be Dr. B.S. Ramakrishna. We have a panel of national and international study group, which will be guiding the journal. And we request the manuscripts from all the experts. I know the lot of volume of work we are doing across Tamil Nadu, both in the government and private sector, both in all the fields, in the luminal, hepatology, and endoscopy, I think. And we have a largest number of postgraduates in the entire country. So I don't think any difficulty in submitting articles, and we expect all the articles to be, that can be original articles, review articles, case reports, and case series. And we expect the first edition we are expecting in January 2021. So these are the things we are really excited about. And that's all. Anything anybody wants to ask something?
Yeah, well, I just wanted to know about the journal. Is it going to be an e-journal or it's going to be a hard copy?
It is both, sir. It is both online as well as a hard copy. Both. Because since Ramakrishna is involved, I think it's going to be a very good quality. Hopefully we'll be indexing in 1 or 2 years. So the indexed, it will be indexed in a course of time.
I'm sure. I have no doubt because you have all intellectual crowd here in Chennai, especially concentrated. So I'm sure you can do a lot of good work. So no problem.
Yeah. So only thing is we have to encourage our postgraduates and students to write up, because the basic point is the initial hesitancy to write up. Because one thing I found out is a lot of foreign journals one, it's a any journal, if you want to publish, there is a lot amount of money involved. So if you want to publish in Lancet Public Health, for your journal to be published, you have to pay $4,000. That is hugely money related. Lot of other foreign journals, I feel, even if you send a journal without any review, they simply return back. That again is a main drawback, whether review properly or not. So one thing is we have to identify our students to write up nicely, and BSR is an excellent guide to how to write up. And so things we are looking for the postgraduate to pick up. So hopefully, I think this is one of the exciting thing. Myself and EPEN, entire CMC team and BSR is very much interested, and we will try to achieve that. That is our main thing. Professor TSC, anything you want to add?
Hearty congratulations to the entire team, as headed by Dr. KRP sir, Bala, who have all been, and Ramakrishna sir, and the whole team. Now with Malati madam and Upalu and the whole team, vibrant, and I'm sure Dr. Jayanti is also guiding. So, you have fantastic people in Chennai, so I'm so proud of you.
So, Coimbatore is not the least.
EGM is also Chennai only.
So you guys are doing fantastic. You can put up a center in Chennai, Vijayam. You can put up a Vijayam hospital in Chennai.
Sir.
Actually, the main point is not in Chennai, sir, because basically I want what is even the remotest corner of the Tamil Nadu. Yes. There are a lot of work is going on. So the basic thing is, even on a single case report somewhere in the periphery, maybe Tirunelveli, Nargoi, somewhere that should be highlighted across the Tamil Nadu.
And I think pulling up this ISG task force doing this study together is phenomenal, because pulling up the data, we can get fantastic data published.
Yeah.
Consistency of data has to be maintained, and I think we can show. I think we have to send our data. We are just lagging behind, but we'll do it for the IPD.
Yeah. Right, sir. Thank you. I think we can move on. Vishnu, you are there? I think you are the first presentation.
Yes, sir.
Yeah. Go ahead.
So you can see my slides, sir?
Yeah, yes, Vishnu. Go ahead.
Yeah, sure, sir. Good evening, all the distinguished professors and ma'am. My topic today is pancreatic fluid collection management. This is a case of early direct endoscopic necrosectomy for walled-off pancreatic necrosis. Before going to the real topic, we can have a review of literature. Now, since 2007, after the revised Atlanta classification, this slide has been the same. There are two types of pancreatitis. One is interstitial edematous pancreatitis, another is necrotizing pancreatitis. In those cases, if there is a ductal disruption or necrosis, there is a fluid collection around the pancreas in this case. In interstitial pancreatitis, this fluid collection in less than 4 weeks' time is called acute peripancreatic fluid collection. After 4 weeks, once it has an organized wall, it's known to be called a pseudocyst. In a necrotizing pancreatitis, in CT, we can see a hypoattenuating pancreas, which has lost its blood supply and showing a necrosed part. In less than 4 weeks, it's called an acute necrotic collection. Once we follow it up, 15% of them will progress in size and form a wall and are known to be called as walled-off pancreatic necrosis. Now, this pseudocyst and walled-off pancreatic necrosis are the targets for intervention, whereas when less than 4 weeks, we wait, unless otherwise it's a special case situation. Now, taking the pathophysiology of how this pancreatitis is developed, here is an acinar cell, and here we see the basolateral side where the reticulum produces the enzymes and it gets packed as a folded protein, gets stored in the zymogen granules, and gets released on the stimulation by cholecystokinin, bile, and acetylcholine. Now, if there is a toxic stimulant, what happens is this excess of calcium, there is a small calcium influx here and there. Once, if there is a toxic stimulation, the calcium inflow inside the cell becomes extremely high, which will lead to two things. One, zymogen granules get activated. Second, there will be mitochondrial dysfunction. If there is mitochondrial dysfunction to a very little extent, then there is more ATP which is produced, and apoptosis is activated, and the cell goes one dead. If there is full mitochondrial dysfunction, what happens is, if there is full mitochondrial dysfunction because of high calcium stress, excess of sustained calcium, it will cause total loss of ATP, and that will cascade full necrosis. So less ATP, apoptosis, and full necrosis, full mitochondrial dysfunction lead to full necrosis. How does that fare? This fails because when the stress is more, we'll get acute necrotizing pancreatitis. When the stress is less, you get acute interstitial edematous pancreatitis. So when this necrosis or apoptosis both will ask for inflammatory cascade, which will lead to pancreatic hypoperfusion. We call this pancreatic vascular microstasis, which is the main pathophysiology for developing fluid leak and necrosis. It's usually by hypovolemia, sympathetic activation, excess of angiotensin II. And this will lead to increased release of lipase into the perilobular fatty tissue, and the fat goes in for degeneration. So that's why there will be intrapancreatic necrosis or peripancreatic necrosis. Now, this necrosis can either stay sterile or it can get infected. And mainly it get infected because of the role of intestinal dysfunction, which can come in the form of ischemia, reperfusion, injury of the intestine, a gut barrier dysfunction, dysbiosis because of excess antibiotic use, or because of ileus. In this slide, we can see this is the most common type of necrosis, 95%. Because of alcohol and gallstone, there is excess enzyme dissemination and auto-digestion of the fat. In these two type of cases, this is very rare, wherein there is a duct can directly go in for necrosis. Here, the acini can directly go in for necrosis. So coming to our case, this is the walled-off pancreatic necrosis. This is what we are trying to check. Now, the pancreatic necrosis, the collection can come in the head, body, or tail region. The distribution is mainly because of the extensive, vast blood supply. The blood supply of the pancreas comes from the celiac artery, gastroduodenal artery, and this arcade, and also from the SMA. Tail is predominantly supplied by the splenic artery. Depending on which artery is involved and which part of the pancreas goes for necrosis, the collection gets localized in the tail, body, and head region. Now, these are indications for treatment of a necrotic collection. We drain the necrosis when it is infected, and the signs of infection are progressing fever, culture-positive bacteremia, worsening leukocytosis, persistent unwellness of the patient, and gas collection in the collection. Gas in the collection can also be due to the fistula, pancreatico-enteric fistula, but that's less common. A sterile necrosis, the indication for drainage is actually less. The evidence is less. But when do we drain? When there is luminal obstruction of bile duct, stomach, or intestine, when there is persistent debilitating symptom, when there is ongoing organ failure, and when there is disconnected pancreatic duct syndrome causing fistula. So these indications are there for treatment for necrotic collection. And when do we time it? Generally, we derive this from the surgeon's perspective. Less than 4 weeks, if we try to intervene, there will be more morbidity and mortality. So we give more time for the cyst to mature. In less than 4 weeks, we intervene only if there is worsening organ failure or debilitating symptoms. And the debridement of necrotic collection, how do we do it? Either we can start with the percutaneous drainage, and that percutaneous drain tract, we can pass a laparoscopic instrument and do video-assisted retroperitoneal debridement called VAD. These are surgical approaches, we can say. Whereas when it comes to endoscopic approach, we have transgastric and transduodenal approach, depending on the location of the walled-off pancreatic necrosis. We can either EUS guided, we can do it EUS guided or non-EUS guided. EUS guided is better. Can either leave a plastic stent or a nasocystic drain, or put a lumen opposing metal stent, followed by direct endoscopic necrosectomy. These are the approaches, options there in endoscopic approach. Surgical can be lap transgastric, open transgastric, and open direct necrosectomy. Step-up approach is better than direct surgery, according to Panther trial published in NEJM 2010. Step-up is better. Which step-up is better, endoscopy or surgery? This was published in Tension trial in 2018 by Lancet. Endoscopy step-up compared to surgical step-up is equally comparable, non-inferior, but endoscopy scores over a surgical step-up, meaning fistula formation is more with a percutaneous surgical approach. You put a percutaneous drain and then do a VAD, video-assisted retroperitoneal debridement. 32% of these patients end up at the 6 months with a persistent fistula. Whereas endoscopic cystogastroscopy, direct endoscopic necrosectomy, the fistula rate is only 5%. So endoscopy scores over surgery in Tension trial. Endoscopic drainage depends on the site of the collection and whether duration, whether it is more than 4 weeks, and whether it's infected or sterile. Usually endoscopic approach is for a central retrogastric collection, not for paracolic gutter collection, wherein we put a percutaneous drain. If it's a central alone, we put endoscopic drain. If there is additional component of paracolic gutter, additional percutaneous drain is needed. EUS guided procedures are better than non-EUS, but there are no RCTs. Lumen opposing metal stent, which gives a diameter of 15 millimeter, is better than a plastic stent, which gives a diameter of only 10 French. And after creating a gateway with the lumen opposing metal stent, going on with the forward viewing endoscope and doing a direct endoscopic necrosectomy is better than putting just a nasocystic drain and doing irrigation. And waiting for 4 weeks for the collection to mature is good for EUS drainage, endoscopic drainage, rather than approaching in early case, like 2 to 4 weeks after the onset of pancreatitis. So here we have this endoscopic cystogastrostomy. We created a place. 2 plastic stents are kept and a nasocystic drain is there for irrigation. This may not be sufficient for a walled-off pancreatic necrosis. We have to go with a forwarding-scopy and do a necrosectomy. Now, how do we do it? When Todd Barron started this in 1996, he just opened up the tract with a balloon and directly entered with an endoscope. This had so much of complications like bleeding and tract leak. So that's why Binmoller invented this lumen opposing metal stent, wherein the cyst wall and the stomach wall is opposed and the tract is allowed to be matured, and then an endoscope is passed inside to do necrosectomy. There are several lumen opposing metal stent in the market. We don't go for the details of those things. In this case, I've used a Hanara stent, lumbar stent. Coming to our case, this is a 25-year-old woman. She was last year. She had a pancreatitis attack when she was residing in Delhi. She was postpartum 3 months at the time. She was diagnosed with gallstone pancreatitis based on the imaging and the LFT findings. She was followed up 8 months postpartum. She had another episode of pancreatitis, and this time she had a pancreatic fluid collection, both necrosis and ascites. An MRCP also was done. Disconnected pancreatic duct syndrome could not be established at that time. Post 11 months postpartum, she was followed up. And then she came to us in February end to Chennai Global. We did a US and we found out there was an organized collection. We started her for peri-procedural antibiotics. Antifungals were not started, so those are not recommended. You can see in this MRI image and this CT image, there is a necrotic collection. This was December, not with us. This was December. She came to us in February. Here, the collection is still not organized. Here in MRI, we can see there is acute peripancreatic collection, necrosis, but it was not organized. It was ascites and retropancreatic. You can even see the fluid in paracolic guttus. Now, when she came to us, we allowed the tract to mature, and we did the US. We found the collection is fully organized, and there is necrotic material inside. This is not a clear pseudocyst. You can see echogenic debris inside and a necrotic collection. This requires a bigger stent like a metal stent, and we need to plan for necrosectomy. That was the plan. So you can see we are puncturing the cyst with this collection size is 10.6 centimeter by 8 centimeter. This is the area avascular plane which I choose. I initially do a puncture with a 19 gauge needle, pass a guide wire, dilate the tract with a 10 French cystotome, and then place a lumen opposing metal stent. Distal flange is deployed in US guidance. The stent is deployed in the scope, and then proximal flange is seen in the endoscope. Here, the stent was slightly stuck in the wall, so I had to put a plastic stent before I readjusted the proximal flange. After 2 days, I allowed the tract to mature and the stent to fully dilate. After 2 days, I went in and started doing the necrosectomy with a snare. Here, I don't use coagulation cautery, just catch up with the snare and then assess the vascularity and the viability of the necrosome and try to pull the necrosome out. This can be done in settings, successive sessions. But here in this case, I tried to finish off the procedure because I could see that the entire necrosome was fully free. This one piece, I cut it out together and I removed the plastic stent which was hindering my vision. When I assessed, there was not much of bleeding inside and the necrosome was totally away from the cyst wall. So you have to carefully puncture and reassess with the snare. This is like an entire pancreas which is removed. This is done in one sitting. We have to manipulate and we can get the entire thing out. It was almost 20 centimeter. After removing, you can see this distal flange slightly touched the inside of the cyst. And there was a mild ooze. This was not a major bleeding. It was a very mild ooze. If I had left this metal stent inside, definitely 2 to 4 weeks later, it would have impinged on the opposite wall, formed a pseudoaneurysm or more bleeding. So I had to remove it. This was not needed anymore because all the necrosis is out. I don't need such a big lumen opposing metal stent staying inside the body. Now the tract is fully mature. And entering the cavity, we can see that all the necrosis is removed and this is very clean cavity. Just in case if there is any disconnected duct so that the collection reaccumulates, we need to put a plastic stent. So in this case, I left 2 plastic stents in situ, one 7 French and one 10 French. So in the summary of this case is on 25th February, we did this case. On 27th February, necrosectomy was completed in 2 days. Lance was removed, 2 plastic stents was kept. The plan will be after 3 months, she was asked to come back for follow-up with an MRI, MRCP, assess the ductal integrity, remove the stent, at the same sitting do a lap chole also for a gallstone pancreatitis. But she came to us on March also. This time, there is another complication of this pancreatitis. She had a localized ileus. In this, you can see the stent and this resolution of the collection. This part of the stent is in the stomach. Here you can see the local jejunum being focally dilated. We thought there is an obstruction. We ruled out the mechanical obstruction with the MR enterography. It was just a focal ileus which settled on its own after starting the patient on liquid diet for almost 3 weeks. So in this case, we did an early direct endoscopic necrosectomy. I didn't put a plastic stent or irrigation, nasocystic drain for irrigation and come out, because I have data to suggest that published in 2009 GI endoscopy, 88% success rate is available with the direct endoscopic necrosectomy rather than just leaving plastic stent and nasocystic drain irrigation, wherein the successful resolution of the cyst happens only in 45% of the patient at the end of 3 months. Endoscopic necrosectomy, the tools are, we have basket, we can use Rocknet to remove, we can use a snare. I personally prefer a snare which is inexpensive. This is an endo-rotor which was initially introduced 4 years ago for removing laterally spreading tumor. There is a blade which is rotating here. Now this is also used in necrosectomy now. We can keep the tip in the necrosome and slowly all the necros can be removed with complete irrigation. It's still not available with us. The complications of necrosectomy are bleeding can happen, can perforate the wall. And if instead of CO2, if we use air embolism can happen. We always use CO2. And any stent which we place can migrate either distally or into the stomach or into the cyst cavity. That can be managed. Infections can happen that can be controlled with peri-procedural antibiotic, which is carbapenem and 3rd generation cephalosporin. So when you put a lumen opposing metal stent, usually the follow-up is call them within a period of 6 weeks, assess. Maximum the stent can be kept for 6 weeks, after which remove the stent and exchange them with plastic stents. Do an MRCP at 3rd month and see if there is disconnected pancreatic duct. If there is a disconnected pancreatic duct, leave the 2 plastic stents in situ lifelong, no problems will happen, and follow up. If there is intact PD with complete resolution of the cyst collection, then remove all the stents. If percutaneous drains were placed for palachoic gutters in the same setting, remove them and assess as early as 4 to 6 weeks once the collection is completely resolved. Leaving the stents for a longer time will lead to pancreatic percutaneous fistula. So in conclusion, I'll leave you with this slide. If you see a walled-off pancreatic necrosis, we see whether it is sterile or infected. And if it is a central collection, which is adequately accessible by EUS, and it doesn't have any large paracolic gutter collection, directly go for EUS-guided metal stent placement for drainage. If there is excess amount of solid debris, you can start the direct endoscopic necrosectomy once the stent is fully expanded. You don't have to wait. And do the endoscopic necrosectomy in short sittings. If we can finish off it in short sessions, do it off in one go. Otherwise, if you take more time to do the necrosectomy, don't prolong the anesthesia. Instead, do it in sittings like on every 3rd day or every 7 days. If the amount of debris is resolved, remove the lamps once the cyst is fully clear and place a plastic stent. And the plastic stent to be removed once the disconnected pancreatic duct syndrome is ruled out.
Congratulations for a wonderful presentation, Vishnu. I have a couple of questions. One is the disconnected duct syndrome. Would you also do a regular ERCP and put in a stent through the major papilla or a minor papilla if major is inaccessible?
Not when the dust is still not settled, not in the acute setting. Maybe after 3 months, if the MRCP is not helpful, then do ERCP. That is a recommendation from the recent guidelines also, which was published by Todd Barron. Because since its MRCP is non-invasive, we can directly go for it. For some reason, if there is a residual collection wherein we cannot assess the ductal integrity fully, where the mapping of the duct is not seen, then probably do an ERCP and place the transpapillary stent.
And a second one comment on your procedure. When you saw a bleed, did you go ahead and do a Cryograsper coagulation of the bleeding spot or not?
I did not do, because I know that it was just a superficial scratch. I gave a wash, it stopped. But had it not stopped, I always had a backup of my IR guy and the surgeon. And had it not stopped, had it been a terrible arterial bleed, I had the IR team with me. And to help the IR team, sometimes we can just leave a clip in situ so that IR team knows where we have to inject the dye and,
Absolutely. You're right. And we stopped doing the Hanaro stent because sometimes what happens when you're releasing a Hanaro, you have to come all the way into the esophagus and then release. Otherwise, it'll get completely retracted into the cavity. We have seen such demonstrations even in endoscopy workshops by foreign faculty. I'm sure you remember. So now the hot Axios is so good. You don't need cystotomes, no dilatation, nothing. In fact, I was telling, it is the simplest procedure anyone can do. I was saying, see, 33 years of my experience and toil is completely gone. Even the junior most resident can put in a hot Axios stent without any difficulty. It's so fast. It's just lovely.
It's a very good study. I've done in 5 cases, but the cost differs us from doing all
True.
cases.
Absolutely, I agree with you.
5 cases, it's very good, sir. It's very good study.
I just have one question. Can I ask Dr. Viji? Asymptomatic one, does it depend on the size? Are you going to interfere or not, Dr. Vishnu? Excellent presentation. Asymptomatic one, when will you interfere?
Ma'am, asymptomatic, if it is sterile, I would not interfere. Just follow up and wait and watch. This
Even
case,
size?
no, ma'am. Size is not a criteria anymore. If there is debilitating symptom, if there is an infection, if there is infection, only then intervene. Sterile necrosis, asymptomatic, patient is very well to do. I mean, patient is not losing weight, able to eat, able to function, no fever, do not intervene.
Because they say 30% can go for complications, no? So there are no criteria who are the 30% who will go for complications.
Previously, before the West Atlanta, there used to be a cutoff size of 6 centimeters and 5 centimeters. But now, if in asymptomatic, if we intervene, the intervention can bring in more problems rather than leaving them alone. So, better not.
Can I ask a question, doctor?
Yes, sir. Yes, sir.
In a acute necrotizing pancreatitis,
Yes, sir.
if a patient has got a pancreatic ductal leak,
Yes, sir.
would you plan to stop or minimize the leak, or you would go and do the pancreatic necrosectomy? What is your, how will you proceed?
It depends on the duration and where the leak is, sir. If I found out that there is a large infected necrosis, with the DPDS, I would probably take up an endoscopic approach. And if the leak is more in the paracolic gutter, percutaneous approach also. Whereas if time has gone and if there is a nice organized collection and the leak is also evident in the distal, then probably I'll give it to the surgeons to do a distal pancreatectomy. Did I answer the question correctly, or the question was different, sir?
No, my question is, will you plug it, or will you remove the necrosis? Which will you give a preference? Patient has got both. He has a leak also, he has got a necrosis also.
Sir, there is a leak.
Where will you go on?
The leak is there and the leak is into the cyst cavity. So you're already establishing a communication between the cyst cavity and the gastric lumen. So there is no additional need for a simultaneous transpapillary PT stenting. This is
actually the Chandigarh group differs because you've seen all the studies. They always do a major papilla cannulation. They demonstrate the leak. They put a stent across that bridges and closes the leak. Because otherwise, what will happen is you have put in a stent. If you remove it also, again the leak will continue. So you'll have to tackle the leak. No?
Personally, I would like to do that, but since I'm in the forum, I have to talk EASL guidelines. EASL guidelines says that don't do that. Only one.
No, I think we take the guidelines as a pinch of salt, just to give us a flavor. Yes. But I think we have to work on our own patients and how they would. I think PG should pass comments on
Doctor,
this.
your presentation was excellent. There was a study by Neoptolemus in UK, where he said that the patients of acute necrotizing pancreatitis, only 25 to 40% have ductal disruption. Not all, everyone has actually. That's why I asked this question.
Yeah, correct, sir, correct. So you were asking whether all WPOPN will have disconnected duct. That was the question. Yes.
Good.
I agree, sir. 30% only has. Correct.
Thanks, Abhishek. Maybe we'll move on to Dr. Naveen. Naveen, are you there?
Yes, sir.
Yeah, you can share your screen.
Sir, are my slides visible?
Yeah.
You want me to start, sir?
Yeah, you can start.
Yes, sir. So, good evening, everyone. Today, I would like to discuss about 2 cases of gastrointestinal bleeding, which were managed in our institute, that is SIMS Hospital, Vadapalani. Coming to the case 1, is a 54-year-old gentleman. He came to our hospital, came with complaints of constipation since 8 days, bleeding per rectum since 1 day. So he had 3 bouts of bleeding per rectum. Each bout was approximately around 100 ml. It was only fresh blood, which is separate from fecal matter. There is no history of any hematemesis, melena, fever, abdominal pain, rare history of liver disease, jaundice, vomiting, loss of appetite, loss of weight, loss of consciousness, syncope, dizziness, or diaphoresis. Coming to past history, he had a history of mitral valve replacement, and the indication for that was rheumatic heart disease and infective endocarditis. Presently, the patient was on tablet acetron. On examination of the patient, per abdomen, it was soft, no organomegaly, no free fluid, no tenderness, and no mass per abdomen was felt. On per rectum examination, blood clots were seen and no mass was felt. Patient was hemodynamically stable. Coming to basic blood investigations, it showed hemoglobin of 10.3, total TLC of 17,600, platelet count of 268,000. Renal function tests and liver function tests were normal. INR was elevated and it is 2.28, and PT was 30 and the control was 15. Therefore, acetron was withheld. So, coming to the risk stratification of the patient, most acute lower GI bleed will have a spontaneous hemostasis, which does not require an admission or evaluating the patient. And the most common causes of the lower GI bleed in Western countries, it is diverticular bleed, whereas in tropical countries, it is colorectal polyps or the neoplasm. So why do we need a risk stratification? Because few patients may land up with severe bleeding. And how do you define a severe bleed? It is a continued bleeding within the first 24 hours of hospitalization, requiring 2 units of packed red blood cells or a drop in hematocrit by 20%. So what are the predictors of this severe bleed? They could be tachycardia of heart rate of more than 100, hypertension with systolic BP of less than 90, syncopal attacks, 2 comorbid illnesses, use of aspirin or other anticoagulants, witnessed rectal bleeding on presentation, and a non-tender abdomen. So there is one more easy to guide whether the patient has to be admitted and evaluated or not. This is shock index. It is a ratio of heart rate to systolic blood pressure. If the score is more than 1, it could be considered as unstable. Admit the patient and evaluate. If the score ratio is less than 1, consider the patient as a stable. Then calculate the risk score based upon a Oakland score. And the parameters that are included in Oakland score are age, gender, hemoglobin, blood pressure, heart rate. So based upon these parameters, Oakland score will be calculated. And if the score is less than 8, consider it as a minor bleed, and you can manage the patient as an OP patient. And if the score is more than 8, admit the patient and evaluate. So this patient, we have done a CT, a contrast CT on the day of admission, which showed colonic diverticulosis throughout the colon. You can see few diverticulae over here in the cecal region. And in this section, you can see diverticulae over here. So diverticulae were seen throughout the colon, and there is no extravasation of contrast. Therefore, the source of bleed was not identified in imaging. So then patient was properly prepared, bowel preparation was done, and colonoscopy was done. And the scopy was passed till terminal ileum. And the findings were the mucosa of the entire colon as well as the terminal ileum was blood stained. And there is no active bleed, or there was no spurting of blood, or there was stigmata of recent hemorrhage. Therefore, in colonoscopy also, we couldn't find the source of bleed. So after the colonoscopy procedure, he had persistent to have bleeding per rectum with a drop of hemoglobin by 2 grams and developed hypotension. BP was 100/60. So what could be the source now? It could be either in small intestinal bleed, or it could be an upper GI bleed, or we have missed the source of bleed in the large intestine. So one clue what can give us whether the suggestive of upper GI bleed is if the BUN by creatinine ratio of more than 30, it could be a suggestive of upper GI bleed. Therefore, this patient was proceeded with an upper GI endoscopy, and endoscopy showed no active bleed or no stigmata of recent hemorrhage. So at this point, patient was diagnosed as an obscure overt GI bleed because there was no source of bleed identified in endoscopy, colonoscopy, as well as imaging. So what could be the possibilities for obscure bleed in this patient? Either it could be missed in the scopy, or the lesion was so difficult to identify because of hypovolemia or the sedation, like opiates, usage of opiates, or if the lesion is behind the fold, or blood clots obscuring the lesion, or else the lesion could not be within the reach of the scopy, that is the small intestine. So this is a table showing the etiology of most common cause of obscure bleeds. Either it could be overt or occult. So the upper GI tract lesions could be Cameron lesions, Defilius lesions, or GAVE. And the small intestinal lesions includes angioectasia, diverticuli, Meckel's diverticulum, neoplasm, ulcerations due to NSAID abuse or infections, aortoenteric fistulas, or AVM malformations. And the colonic causes angioectasia, diverticulosis, hemorrhoids, and varices. So what next? Shall we proceed to a relook endoscopy, or the options we can have is either relook or angiography or enteroscopy or intraoperative endoscopy, capsule endoscopy or surgery. So what does study says? Study says that capsule endoscopy has an highest in diagnostic yield when compared to all these other modalities, even intraoperative endoscopy or angiography. So studies also say that with relook endoscopy, majority of the missed lesions in the large bowel could be identified, or in the upper GI tract could be identified. And the drawback with disadvantage with angiography is the patient has to be acutely bleeding to identify the lesion, and it can minimum bleed should be rate of 0.5 ml per minute. And enteroscopy, the disadvantage of enteroscopy, it has to be available in enteroscopy, and then skilled endoscopy should be present. And this angiography and enteroscopy are ideally useful in a emergency setup, because as well as diagnostic, we can do any therapeutic procedures if required. And surgery should be the last option. So for this patient, what we have decided to, we opened him, taken him to emergency, OT, opened the abdomen. And after opening the abdomen, we found a 1.5 into 1.5 centimeter nodule, which is 15 centimeters distal to the digestion. We thought it could be GIST, and this could be the source of bleed. So it was excised. After excising that nodule, the mucosa was normal. Then a scopy was passed through this excised part only, making it as an enterostomy 1. And the scopy was passed till 100 centimeters of the terminal ileum. So the total small intestine was normal, and then our mucosa was normal. So one thing, theory part, what I would like to say here is, when doing an intraoperative enteroscopy, try to see for the lesions while intubating rather than withdrawing. And one more thing is, try to manually occlude the small intestine distal to the scopy, so that the entire intestine would not be inflated and does not obscure our view. So because the scopy was not passed beyond that distal 100 centimeters, another enterostomy 2 was done, which is in the terminal ileum proximal to the IC valve, and the scopy was passed anterogradely. In this findings were blood smeared mucus, which is seen in the cecum, and no active bleed or no stigmata of recent hemorrhage was found. So what next? Because after doing an imaging, endoscopy and colonoscopy and intraoperative enteroscopy also, we finally decided that the bleed could be in the large intestine only. So we decided to do a blind right hemicolectomy, followed by an end-to side ileocolonic anastomosis with the primary closure of the jejunostomy, where the nodule was excised. So why not total colectomy? Why only blind right hemicolectomy is? We came to an assumption, studies showing that even the most common causes of the obscure overt bleeding could be of a large intestine source could be either diverticulosis or angiodysplasia, most commonly which will bleed from the right side rather than the left side. So we decided to do a right hemicolectomy than a total colectomy, because the mortality and morbidity is also more with total colectomy. So this is the resected segment, which is showing diverticulae. So post surgery, after the surgery, patient had again parectal bleeding with a drop in hemoglobin requiring 4 units of packed red blood cells. We thought it could be a retained blood. Later days, patient became stable without any further drop or bleeding per rectum. And histopathological examination showed that patient is having diverticulae with diverticulitis, and the nodule which we saw, which we thought it could be a GIST, came out as pancreatic heterotopia. And CT aortogram was repeated after the surgery, which showed no extravasation of contrast, and all the blood vessels, arteries, and veins were opacified normally with contrast. So coming to the second case, she is a 74-year-old lady, came to our ER presenting with bleeding per rectum since morning 5 a.m. She had 3 episodes of bouts, each episode of 100 ml. 2 episodes were after hospitalization, which is fresh blood, which is separate from the fecal matter, associated with dizziness and diaphoresis, not associated with any abdominal pain, vomiting, hematemesis, prior history of liver disease, loss of weight, loss of appetite, jaundice, fever, syncopal attacks, or loss of consciousness. Coming to the past history, patient, she's a systematic hypertensive and she's on antiplatelets, and the indication was primary prophylaxis. On examination, BP was 90/60 with a heart rate of 100 per minute. On examination, per-abdominal examination, patient was soft, no organomegaly, no free fluid, and no tenderness. Per-rectal examination, the finger was stained with blood. And proctoscopy showed a grade 2 hemorrhoids at 3 o'clock position, and the fresh blood was seen. So blood investigations done on the day 1 of admission showed hemoglobin of 9.6, PCV of 30, liver function tests were normal, renal function tests were normal, PTINR were normal. Hemoglobin and PCV were repeated after 6 hours, which were no significant drop was noted. So after proper bowel preparation, coloscopy was done, and the findings in the coloscopy was, here the scopy was passed till cecum, and the findings were rectum was filled with blood. The remaining part of the large intestine was normal. That is cecum, ascending colon, transverse colon, descending colon, and sigmoid. All were normal except for blood filled in the rectum. Because the patient had an hypotension, OGD was also done at the same day, which showed no signs of any stigma of recent hemorrhage was found. So we thought at this point, it could be due to, the bleed could be due to hemorrhoids only, and the patient was evaluated with cardiac evaluation and planned for banding of the hemorrhoids in the next 2 days. So on the day of procedure, when we planned for an banding, she had one more bout of bleeding, which is of 150 ml. And on the third day before the procedure, we have repeated in hemoglobin, which was 8.3, and compared to day 1, which is 8.9, and it is not significant. So again, we thought it is not significant bleeding and thought it could be either due to only hemorrhoids only. And the patient was shifted to OT, planned for hemodectomy. So intraoperatively, when planned for the banding of the hemorrhoids, we observed that the blood was coming from above the rectum. Therefore, the banding was abandoned. Patient was shifted to CT and abdominal angiogram was done, which showed no extravasation of contrast except for mild hepatomegaly. So at this point, the patient was diagnosed to have an obscure overt GI bleed. So after 3 hours, patient continued to have persistent bleeding per rectum around 200 ml, and the hemoglobin repeated, which was dropped to 6.9 very significantly from 8.3 in a very short period. Therefore, patient was planned for exploration. So on OT table, before opening the abdomen, patient, we thought of doing a relook colonoscopy. Therefore, colonoscopy was repeated second time. This time, in the second time, blood smeared mucosa was seen up to cecum, which was not seen in the first colonoscopy. Relatively, flesh blood was seen in the cecum. So patient, we decided to do an intraoperative enteroscopy by doing a small enterotomy, which was done around 15 centimeters proximal to the IG junction. Fresh blood was seen in the cecum and ascending colon. Small intestine was normal. There was no active oozing or no stigma of recent hemorrhage noted. Again, no source was identified. So in this patient also, we decided to do a blind right hemicolectomy, thinking that most common source of bleed could be in the right colon rather than the left, which could be either diverticulosis or angiectasia. So this is the specimen which is showing divertically after the resection. So histopathological examination showed a cecum divertically measuring of 5 mm, and the section showed wall of colon with mucosal outpouching extending into the serosal adipose tissue. Then there is no muscular layer around the mucosal outpouching. Post-operative period, she had transient melena for a few days. It could be a retained blood, and there is no significant drop in hemoglobin, and she well tolerated oral diet, and thus she was discharged. So this is an overview. If the patient has an overt GI bleed, if there is no source identified in OGD and colonoscopy, and there is no source identified in imaging also, and if the patient is hemodynamically stable, proceed with a capsule endoscopy because it has an highest diagnostic yield. So when do you do a capsule endoscopy? Timing should be as soon as possible, ideally within 3 days. And if the patient is unstable, proceed to an angiography or enteroscopy because we can do an intervention simultaneously. Coming to this summarizing. So occult GI bleed, it accounts for about 5% of the total GI bleeds. More than 60% of the occult GI bleeds, the source will be in the small intestine. Safe and effective non-operative therapeutic interventions have been obviated the need of surgery in many patients. Still, conventional operations continue to be the life-saving, like in our cases where we had done a blind hemicolectomy. Thank you.
Naveen, I have few comments on your presentation. First of all, see, the commonest cause of obscure overt GI bleed in the elderly. I think the first patient, what was the age of the first patient?
First patient was 50, sir.
50. Yeah. 50, 60, 70, the 5th, 6th, 7th decades. The commonest cause is still angiectasia.
Yes, sir.
Because, you know, I've been doing capsule endoscopy, video capsule endoscopy since 2003. And we're going through literature, and we have also a collection of cases of obscure overt or obscure ceased bleed. You see, the commonest lesion is still angiectasia. If you don't have access to video capsule endoscopy, or if there is a massive bleed where you cannot, have time in doing a capsule endoscopy, then I would probably recommend going through an enteroscopy to look into the small bowel. If you still see today we have the motorized power spiral enteroscope, we just can completely fathom, see, within 45 minutes, to 1 hour, orocecal transit time is only that much, 45 minutes to 1 hour. So you can reach the cecum. In the majority of the cases, if there is no obstruction hurdles on the way. So I feel that a pan-enteroscopic evaluation has to be done before you encompass a decision to make a surgery in these patients. If you don't have any of these, you cannot do a video capsule, you cannot do the motorized power spiral, which can go through a full length of the small intestine. What you should do is you should do a lab-assisted pan-enteroscopy. Here, what you should do is in a lab-assisted pan-enteroscopy, if you take the 6 meters of the small bowel, we make an incision in midway, and then go with your endoscope this way and that way to reach the pylorus, and here you have to reach the ileocecal valve. So if you see any treatable lesion, you can just treat. See, obviously in your case, the first case, that was an incidentaloma which you thought could be a cyst, but it was a bacterial cell rest, which is not going to be the cause of bleed. You assume that it could be diverticular bleed and you remove the right side of the colon. So I think a little more care could have been taken. You did a fantastic job in doing an intraoperative endoscopy. But what should have been done is probably make a nick in the center and go through all the 3 meters this way, that way, before you decide what could be the cause. So that is my comment on your procedures.
Can I have a comment? Good presentation, but the only thing with this current available investigations, good imaging, all the other things, the doing a right hemicolectomy currently, I don't think I've done any recommended a right hemicolectomy in the recent many years. So maybe a good imaging, a good CT with the enterography, with maybe combining a CT angiogram, could definitely give us information. That's what I just want to make a comment.
Can I make a comment?
Yes.
I think there's one question in the chat box.
Should I finish first?
Yeah, you can ask.
Yeah. Actually, blind right hemicolectomy was a surgical choice many decades ago. Now there is no role of blind right hemicolectomy at all. In your first case, a blind right hemicolectomy was done. The bleeding source is diverticulitis. In the second case, you assumed it was a hemorrhoidal bleed. A patient of hemorrhoidal bleed will not put 150 ml of bleed will not be there. There will be about 30 ml little. It will be, he will never come with a massive bleed, number one. Number two, whenever there is a bleeding in the rectum, there will always be, because the sphincter spasm, the blood will go proximally. And you may confuse that it may be due to something else. So my decision is there is no role of blind right hemicolectomy nowadays. But you have done a good presentation. Excellent presentation.
I think I just want to tell you that Professor KRP, VGM, Dr. TGB, I just want to reiterate, in this era, and obscure, overt or occult blood, we should make all our efforts to investigate, and if not available, you should send to higher centers, and blindly, we should not do this kind of hemicolectomy and other thing. I think this is the moral of the story here. And I remember late 80s only we used to do like that. That time we didn't have all these facilities. CT angio, advanced, or enteroscopy and capsule endoscopy were not available. So blindly we should not do this. This is I think the message.
Naveen, you can stop the screening.
Yes, sir.
You can answer the question. Stop the screen. Yeah.
I think there are just two questions. Can we take up, or it's time for the third case?
We'll take up them, madam.
I think Dr. Sivashankaran Vadivel Kumaran has asked, I think the one ideal site of enteroscopy for intraoperative endoscopy, I think Dr. BGM has answered. He prefers it midway, so that you can go on either side. Any other answer you have, Naveen?
Ma'am, I discussed with the surgical gastro team. They were saying that when an obscure bleeding, we are going to do an intraoperative endoscopy. And if the patient, we could not find the source in endoscopy also, he may need an resection. So most commonly they go with that and right hemicolectomy only. So that if the enterostomy could be done at the IC valve distal to the, proximal to the IC valve, which could be resected in case if the patient requires resection, So they are saying that could be the ideal site for doing an enterostomy. Rather
I
than
think that's very practical by the surgeon.
Yeah.
And then another one, role of dynamic angiography.
yes, ma'am. Angiography can pick up everything, and it requires a minimum bleed of 0.5 ml per hour per minute. But what patient may not have the acute bleeding at that time. He needs to be actively bleeding to identify the lesion also. And this patient came to us during the COVID period, and one of our radiologists were quarantined at that time, ma'am.
I know we have a lot of difficulties. Naveen, congrats. But what I would request you, next time the surgeons call you for an intraoperative enteroscopy, tell them to make a nick in the center. You go through fully 3 meters this way, 3 meters that way, so that you finish a lab-assisted pan enteroscopy. So that should be the way to go. And then if there is a treatable lesion by endoscopy, many times it could be 60% of the times angiectasias. You can just do a coagulation, you can do a hemoclipping, you can do whatever, thermal coagulation or APC, anything can be done. So just do it endoscopically and come out. So you can save the patient
Okay, sir.
from undergoing unnecessary procedures.
We can move to the presentation. Dr. Palniappan? Dr. Palni?
Yeah. Well, am I audible?
You're audible. Share the screen.
Yeah.
I think Paddington is one person who's making black and white colorful.
I mean,
in the US.
Ubal?
Your screen is not visible still. Your audio is on, but the screen is not there.
Okay.
Yeah.
Yeah, can I start, Ubal?
Yeah, start.
Yeah. My teacher, Professor KRP, Dr. TSC, Dr. VGM, Madam, Malati Madam, and all my senior colleagues and friends. I'm here to discuss about this interesting clinical scenario of a paraduodenal lesion, what to do. My patient was a 38-year-old male who was residing in the United States, IT guy. He presented in September, late and early October, with diarrhea, watery, 2 to 3 times per day of 3 weeks duration. There was no pus, blood, or nocturnal episodes, not associated with any other clinical data what we need, joint pain, eye pain, allergy, rash, oil drops, or wheeze or anything. It was coupled with weight loss of 5 kg in the 4 weeks. There are no similar issues or any other illness or any medications prior. He gives history that I apparently believe that guys in the US used to take what is called a quinoa seeds. It's a millet resembling rice. So that's what the only history what he gave. When he returned to India, recovered, he was stable. But being a person working in the United States, he had to go back. So he was worked up at his native place outside Chennai. Evaluation as shown were all normal. There, the treating faculty for weight loss and evaluation have done a PET CT. These are all done in the outside center before he reported to us. He has shown a paraduodenal node of 2.7 to 2.7 centimeter, for which he underwent an EBUS under general anesthesia, sample which he returned as a benign cyst. At this point, he was referred to us for endoscopic ultrasound. So that is the index consult for us. And this is the CT where we could see the paraduodenal lesion here on the right side, below the liver, adjacent to the duodenum, adjacent to the pancreas. The node, 2.7, 2.7, well circumscribed, round, homogeneous node. With this background, we did an upper GI, which showed few diminutive gastric polyps, small gastric ulcers over the PD ring and incisura. This is the erythema seen in the stomach, and that's the ulcer. Hope you could visualize that. Superficial ulcer, white based. and duodenum was showing mild scalloping. Biopsies was done both. We did a US. In the US, we could identify the lesion lateral to the duodenal wall. This is a radial one, and we could see the node there. A well circumscribed homogeneous node with lost architecture. FNAB was done with a 19 gauge needle along an avascular plane. So the biopsy upper GI was remarkable, but EUS biopsy was returned as positive for neoplasm, morphologically favoring neuroendocrine tumor. Subjected for IHC, the cell block was returned as a well-differentiated neuroendocrine tumor. Mitotic activity was less than 2, but unable to clearly delineate the Ka index. What next? This is a patient with a persistent diarrhea and weight loss with a paraduodenal D2 node showing a well-differentiated neuroendocrine tumor. So we thought that we will do a baseline workup towards neuroendocrine tumor, the biochemical imaging, DOTA-PET, and then to assess what evolves. But for compelling reasons, he had to leave back to United States, where he was worked up, and I could communicate to him telephonically, and I got all the data till date, and I want to present that data also. So this patient underwent evaluation. There also he has underwent upper GI, CT scan. CT developed an allergic reaction, so MRI gadolinium scan was done, as well DOTA-PET, and then US also was done twice, because this is the patient where he is presenting with duodenal ulcers, a short duration of diarrhea, and a paraduodenal lymphadenopathy showing NET. So we identifying the effects of the problem, but where is the primary source? So he has underwent a surgery to identify the primary pathology somewhere in the duodenal gastrinoma triangle. That's what they thought. During surgery, they palpated. They couldn't identify the primary. They did a transillumination. It was difficult. They did an intra-op endoscopy, screened up to D4. No lead. And then they decided what is given actually in this paper. So when you suspect a duodenal gastrinoma, all pre-op imaging failed to localize in 80% of cases. Your CT, MR, angio, or any conventional study, or even somatostatin study, or portal venous sampling, the sensitivity and specificity to identify the primary is less than 80%. So at surgery, what they did was palpation difficult, intra-op endoscopy was difficult, and then they did the duodenotomy, the first part of duodenum. On table also, they could find only a small outpouching just behind the pyloric ring. Initially, they thought it is an outpouching. And then they palpated more. They found a small nodule. Frozen was returned as well-differentiated neuroendocrine tumor. And they resected it. And they also did a prophylactic cholecystectomy, anticipating a post-surgical need for long-acting somatostatin analog. And then the patient is in follow-up. Pre-op evaluation showed a rise in gastrin and chromogranin, which he communicated to me. There was a drop in both gastrin as well as chromogranin levels. 3 months down the line, he is doing clinically well. He did a repeat DOTA-PET also. He is looking stable. So in short, this is a duodenal NET, and our case is probably a gastrinoma coming the bracket of Zolling-Ellison syndrome. The other duodenal nets are non-functional ones, somatostatinomas, paraganglionomas, and a very poorly differentiated carcinomas, which is a very rare. What I want to stress is neuroendocrine tumors are on the rise. The commonest site in duodenum is the first and the second part. Usually and invariably, they lie in the gastrinoma triangle, which lies in this between the cystic CBD, pancreatic, and the D2, D3 junction. And tumors may be duodenal origin or pancreatic origin. What you have to understand is duodenal gastinomas are very small, and they are the commonest, whereas a pancreatic one or very large one, and the metastasis at presentation itself. And neuroendocrine tumors, we have a variety of clinical societies, NCCN, European, North American, United Kingdom is Ireland. And the biochemical evaluation, chromogranin is sensitive, synaptopysin is specific, but we have to understand that false positive can occur in patients with GI, renal failure, or gastritis. The recent PCR-based 51 transcriptase signature analysis may be very, very highly significant, and they are not affected by PPI intake. And in imaging, this paper tells us that the gallium DOTA PET-CT has a very high sensitivity, specificity, and accuracy in identifying neuroendocrine tumors when compared to CT, other modalities, and even compared to MR. MR may be superior in identifying low-volume liver metastasis. So the guidelines, we have to choose what we prefer. And European guidelines, they say that all localized tumors have to be removed, either endoscopically or surgically. When endoscopy, if they are less than 1 centimeter, confined to submucosa, no nodal metastasis, then any ampullary NET surgery is indication, because however small they are, they metastasize. And any tumor which has more than 2 centimeters and any node size, we have to go for surgery. See, those two cases were functional neuroendocrine tumors, and these two are incidentally picked up non-functional neuroendocrine tumors. These two patients. A small nodules, but multiple in the anterior wall, inferior wall, just behind the PD ring also. This is one case. And another case is, in compared to the prior one, these are all multiple small nodules, but non-functioning, instantly picked up. So these were the few diurnal NETs what we have found out so far. To summarize the therapy, neuroendocrine tumors can be well differentiated or poorly differentiated. Poorly differentiated are very difficult to treat. In well differentiated tumors, loco-regional, metastatic, or with syndromes, if it's loco-regional, resect and evaluate for tumor multifocality. If it is metastatic, even then you resect if it is possible. And then you can follow it up with long-acting octreotide or PRRT, which is a peptide-based radiotherapy, lutetium therapy. And if they are liver localized, we can do liver predominant therapy. If the carcinoid syndrome is there, again octreotide or lanreotide. If still symptomatic, I want to stress upon that medical management, which is tilotristat, which inhibits the symptoms. So this case was presented to highlight that neuroendocrine tumors are rising in incidence. There is extreme diagnostic difficulty. The literature says there is a time delay of 9 months to 9 years. Imaging other tumors, we do only CT scan, that is an anatomical imaging. But in neuroendocrine tumors, we do functional imaging as well as anatomic imaging. And neuronal tumors, particularly, they have a different clinical behavior. Papillary tumors, whatever the size, resect. Suprapapillary, there can be endoscopic or surgical. Syndromes are rare. Infrapapillary, they behave like small intestinal neuroendocrine tumors. Syndromes are common. And these tumors, when they undergo surgery, prophylactic cholecystectomy is a must. So I thank you for your patient hearing. I'd like to take questions.
Yeah, Pani, that was a great presentation. It was primary, not seen, but you located the secondary. So this is interesting. So which can happen many times in small nodules, you just miss. One thing that the Americans could have done is could have followed certain guidelines. See, initially, if you spot a carcinoid or a gastrinoma, that's all the features are there, full-blown features, or you spot a secondary, you're not able to see the primary. The first line of investigation that you do is a video capsule endoscopy, because it can pick up the small nodules. My question to you is, when you were doing endoscopy, did you see the duodenal nodule?
No, the endoscopy was done initially outside center where it was referred. And then it was done twice in the United States Center also. One was in Stanford and the other one is another place. None of them, and Introp also. Introp, they are screened up to D4. They are in a trans-illumination on-table evaluation, palpation.
But they located the nodule in D1, right? The small nodule.
It was just behind the pylorus. It was a post-pylorus. Outpouching, which on table also initially they thought it is an outpouching only, but suspicion, they cut open it. They noted a 3 mm, 4 mm nodule.
Here, the double camera video capsule endoscopy, the so-called the Poland 2, could have easily spotted, because one camera looking down, one camera looking upwards, could have probably spotted this nodules, because otherwise below the pyloric neck we can always miss.
Dr. Maniappan?
Yeah, yes, sir.
Yeah, excellent presentation and a very eye-opener presentation. as you said, that the incidence is increasing. It is not the incidence is increasing. Incidence is the same. But because we have so many diagnostic modalities latest which are coming into vogue, we're able to diagnose them. Otherwise, incidence is the same, number one. Number two, when you get the history of diarrhea and then weight loss and then some kind of, so I myself have an idea that the patient may be a case of Zollinger. So the 50% of the diagnosis already made in the history itself, number one. Number two, your endoscopy has confirmed it. Yeah, you want to tell?
Yeah, actually the patient was, that's what I reiterated that he was referred only for US. That's the exact clinical scenario. And I thought the diarrhea is related to the quinine seeds which he has taken when he was in the United States. He also gave an history that his wife also had diarrhea for just 5 days after taking the seed. So practically what we thought was the diarrhea is not in the picture initially we thought.
Yeah.
We were always targeting the node, that lesion paraduodenal node.
Many times these patients actually, 50% of the duodenal net are asymptomatic, but we have operated few cases.
Okay.
Laparoscopy. The moment you found a nodule in the duodenum and a nodal lesion, it is a metastatic lesion. But the only thing is very unexplained. The K index was very less. It showed only mild. The K index is less than 6 is normal. 6 to 10 is intermediate. Above 10 is high bad prognosis. So the K index is only less than 3, what you have shown. So there is some kind of discrepancy in the interpretation of the investigation and the imaging actually. So many times the primary is not found.
No, sir, may I interrupt, sir? So if it is, the K index is very high, you mean to say that it is a grade 3, which means the FDG PET would have picked up. The FDG PET didn't pick it up. So it is correlating, sir, because it is a low-grade tumor and it has picked up. So I think it is corroborating.
No, most of the time, Dotanac will pick up.
No, Dotanac will pick up only low-grade tumors. High-grade tumors, which have very high index, will not pick up.
No, even it picks up. Even Dotanac, actually, we have seen CT failed, MRI picked up, then Dotanac picked up.
No, Dotanac pick up if it's a well-differentiated tumor and low-grade only will be picked up with Dotanac. Whereas if it is poorly differentiated or high-grade,
the literature says the Dotanac has got the highest sensitivity as compared to any other investigations. Gallium Dotanac.
For poorly differentiated DOTA-PET,
functional imaging is the only choice which can pick up all these things. Plus US, which you have done. Very interesting case. And what they have done, it's very appropriately, they have done it, what is necessary. And the only thing is, my question is, in your practice, you have picked up some nodules in the endoscopy. Would you leave them like that, or would you go in for further investigations? Because many of the duodenal non-symptomatic lesions may be associated with some syndromes like Lynch, MEN1, and tuberous sclerosis, and so many other things.
Agreed,
you have to investigate these patients by other investigators. You may miss it actually.
Actually, yes, sir. Yes, sir.
Very complex case, nicely presented.
Sir, 1 minute. Palani, stop the screening so that everybody can be seen full screen. Stop the screen. No?
Dr. Palaniappan?
Yes, sir.
A nice complex case you nicely presented.
Yes, sir.
I liked your side slides also, a lot of photographs also.
I think I learned this from you, sir.
Number one question is, you know what is the other definition of NET, net? It is never evaluated thoroughly in one go. Never evaluated thoroughly in one go. So it is not surprising at all. The patient was coming from America and you are investigating and you are asked to do only a certain job. Then he is going back to that. There are two things we have to learn from this case. One is however small the nodule, and you have to be very carefully see in the first go itself. Even if it is, what I do nowadays is, even if the patient referred for US, I do thorough upper GI endoscopy examination, and that may give a clue. The other thing VGM pointed out nicely, the primary can be so small, and what you were looking at the paraduodenal was a secondary. So maybe Japanese way of looking at the upper GI endoscopy could have picked up the primary lesion. So before doing US, better we once more, how many times they have done earlier also, better to do in the same anesthesia, we do the upper GI endoscopy. The third thing we have to learn is even the smallest nodule, and we better to take biopsy, because the reason why is on the table assessing a small nodule through the duodenotomy is a Himalayan task. I don't know how they have done it. I recall incidents where when I was supposed to do under anesthesia ERCP, what ampulla was looking so big, it becomes like a flat lesion under anesthesia. It's difficult to cannulate. Same analogy with a small nodule. Probably whoever has done it earlier, they could have overlooked this small nodule in the duodenum. That is my impression. So I think this case brings about a lot of lessons to be learned, even for the senior gastroenterologists also. And very well done. And I'm very happy that you brought out this case.
Thank you, sir. I have time, sir. One question. Dr. Vijayam, can I ask?
Go ahead, Punit.
Sir, actually, in all NETs, what the literature says is a patient with NET who undergoes any anesthesia or any surgery, they may land in crisis. This crisis will be like a potential hemodynamic instability, which will respond only to octreotide and not with fluids or not even for dopamine or whatever vasopressors. But do we encounter such scenarios? That's what I thought, because we are doing many endoscopies for many people who have NETs, upper GIs, colon surgery also. Even the surgeon, Dr. TGP, is there. Anyone of us have come across an unexplained shock, sir, in a NET patient.
Sir,
1 minute, sir. Should we keep octreotide as an emergency tool in our endoscopy room? Because we don't know which patient comes with what.
I have faced a problem 3 decades ago. This patient had multiple ulcers in the duodenum. And I think they probably suspected and they did a GJ. Following GJ, patient had intense diarrhea. And of course, then further evaluation, it was a Zollinger-Ellison syndrome.
Okay.
We have evaluated almost in the past 3 years about 40 neuroendocrine tumors. Majority were in the duodenum. Some were in the esophagus, stomach, rectum. I made a presentation to Tamil Nadu ISG also in Kanyakumari. So we have never seen a crisis situation requiring octreotide, because most of these are non-functional. They had one gastrinoma, which is Zollinger-Ellison syndrome, with multiple gastric ulcers and nodules. We could diagnose that. And to TGP sir's question also, even a low-grade Ki-67 less than 2 and KRAS less than 2 can also metastasize. That has been well shown in literature, and we have also seen some metastatic lesions like that. So a rectal, lesion, which is low-grade, but metastasizing to the liver. From the liver nodule, we started working up, and both turned out to be neuroendocrine tumor. So such sort of things happen. But unless otherwise, it's like a carcinoid syndrome. We do, at least I have not seen one. In 33 years, we have not seen. Maybe KRP sir and TGP sir, TSC should all add some light to this. Have you seen any crisis situation endoscopically when you are tackling this nodule that you require any intra-endoscopy, octreotide, or such a thing?
Okay. In a functioning tumor, I have come across only once. So you have to be very careful. So I made a point that get the serum chromogranin or any way of assessing the functionality of the tumor before embarking on the biopsy. Suppose you have sent the serum for chromogranin or other markers for the functionality of the tumor, I will always wait for this before going for the biopsy. I learned it in a hard way. So I'll wait for that. Any nodule, you should not be hurried to take biopsy. Whatever you see, you take a biopsy. Even if I find out, I do not do biopsy nowadays. Whether it is going for EMR, ESD, no biopsy, or it is going to be NET, is a functioning or non-functioning, then I embark in a second sitting biopsy. That is a very important thing. I think
can you share your experience? What prompted you to do this?
Which one?
When we see a nodule, we all biopsy. But what prompted you not to biopsy? And you said you had a...
I have also made a mistake. I have come across like this. After that, any nodule...
What was the problem that happened? So that is what we wanted.
A sudden drop in the BP was there. Oh. So I was wondering, what is this? Some kind of shock, whether it's due to anesthesia or NET or is circulating hormones. I could not figure out. But luckily, we came out of that. After that, I made it very clear when we are suspecting NET and make sure that whatever way possible it is functioning or non-functioning and get a thorough all the investigation, then you take biopsy. This is a message I want to tell you that. Yes, Palani.
Sir, as Ubal, now we are doing a paper on collecting the data of IBDs and previously done for the poisoning also phosphorus. I thought whether we can start collecting all our data on NETs. We all
very good idea. Actually,
for
we
NETs.
Lot of non-functioning NED quite a bit. All of us will take it. Nothing will happen to our patients. So I think this is a time to take NET also. We individually will be seeing few cases, but when you collect cases, it becomes a big a number from Tamil Nadu. I think our patrons are there, Dr. KRP and Dr. BB there, and Malvi also. We can start that.
I agree. We are seeing more of this sort of problems. I think we can start a study.
Yes.
Actually, NET is always a problem. That's what I said. Never evaluated thoroughly.
So there's one question from Hyderabad. Why prophylactic cholecystectomy in NET? Yeah. Hyderabad, Dr. Srinivas has asked you.
Madam, these patients, tentatively or definitely, they might need anti-proliferative and anti-hormonal control management by somatostatin analogs, which have a complication of gallstone predisposition. So to avoid that complication, these patients mandatorily have to undergo a cholecystectomy.
I think Dr. Srinivas will be, I think you'd have got the answer.
That's a very good answer, actually. I was also wondering, actually. Actually, before you investigate any patient of a nodule or endoscopy, blood investigations, serum markers, chromogranin A, synoptopazine, urine 5-HAAA, blood you should include serum insulin also. Then you go and do that, because sometimes a patient may have a carcinoid or insulin, I do not know what. So
gastrin also. Insulin.
Serum gastrin.
Both.
Yeah.
Actually, we recently had a patient. I think many of our senior colleagues, professors would have seen the patient. He's an ENT surgeon. He was diagnosed with a small vocal nodule. He is 37 years old. Small vocal nodule, which was turned as neuroendocrine carcinoma. It was grade 3 on diagnosis itself.
My goodness.
And he survived just for 12 months to 13 months, and it was a very difficult scenario. And we are seeing more and more of complicated scenarios, and it is a huge teamwork. So I think NET needs a huge teamwork, and it's an evolving field. And I need all the senior professors to support that. Can start a paper on that, and surgical colleagues, Dr. TGB, Professor TGB.
I did not get it. What happened to that small vocal nodule? He survived.
He had a vocal nodule, which was returned as grade 3 neuroendocrine carcinoma.
And he survived only for 12 months.
No, he became gradually sick. And 1 month back, he was with us. He was in a very difficult scenarios.
No, you had a pulmonary mets and other things.
It was spread everywhere, sir. Pancreas, stomach, duodenum, lungs. What I thought is the first biopsy itself told us that the possible prognosis. It was neuroendocrine carcinoma on day 1 itself, though it was a very, very small nodule.
Didn't respond to chemotherapy, sir?
No, sir. He came, as Professor TSC told, he came to us only towards the end. So he was treated in another center in Chennai, where he was given chemotherapy. He was treated as per protocol, but an unfavorable outcomes.
Even lutetium dotatate.
No, sir, it was day one. It was neuroendocrine carcinoma, where lutetium was difficult.
There's one question from Surat. When EMR, ESD, or only medical management?
Good question.
Yeah, there is no one. Only medical management is. That's what I projected in the European neuroendocrine tumor guidelines, madam. Any tumor, resect. That is what the ENET says. Correct. What thing is whether you are resecting endoscopically or surgically. So it is papillary, pre-papillary, or infrapapillary. Papillary, any size surgery. Suprapapillary, less than 2 centimeter, limited to submucosa, no metastasis, endoscopic resection, either EMR or ESD. ESD is always superior. If it's EMR, it could be suction and resection or no suction and resection. Where it is more than 2 centimeter, surgery. And if it's infrapapillary, we have to treat it like a small intestinal neuroendocrine tumor.
And one comment to Dr. Bala.
Yes, sir.
Bala, you will be the
Yeah.
happiest person today along
Why?
with our KRP. You know why?
Yeah.
Tamil Nadu ISG getting questions from Surat and Hyderabad.
Yeah.
Become a national ISG meeting.
That's very nice. Very nice.
I think we
The
should
last
do a big
question
round of
again from Hyderabad. Quinoa role in net.
Pardon, madam?
Quinoa role in net.
Hello.
Srinivas from
No, I
Hyderabad
don't.
wants
Sorry,
to
madam.
know the role of quinoa in net.
Oh, role of quinoa. Quinoa, I discussed with my colleagues, and they say that they commonly have the habit of taking that millet seeds, but it's not so common. It's,
So
I think,
in USA, they take, in US, they use quinoa for the salads and all that. Quite
Rice.
common, they take it actually.
so it was an
Quinoa.
incidental. It was an incidental
Weight reduction.
incidental
Maybe.
finding, I think, madam.
For weight reduction they take.
Maybe.
Dr. Maladi, I had it as Innova.
Quinoa.
No, I just to take the patient from home to hospital.
No, from Hyderabad. Question you wanted to know, no? Hyderabad, Surat, everywhere you're getting.
I think today, Tamil Nadu ISG doing this webinar, we get questions from all over the country. I think big round of
Better
applause
than-
to
It's better than the
everybody
local
who was
ISG.
involved in the Tamil
All
Nadu
India
ISG.
ISG.
All India ISG.
Good presentation, and we had actually learned many things from Dr. Paidiyappan. Very interesting case actually. But the guidelines, Dr. Paidiyappan, goes on changing. As you said, 2 centimeters is too big for endoscopy. Nowadays they say only 1 centimeter. You cannot go for 2 centimeter for that. It's only different to 1 centimeter actually. A lot of
I think
guidelines are changing. A lot of things are changing.
Okay.
Every day like that.
Elderly, TGP said, elderly person with comorbids, we still do a 2 centimeter also endoscopically. And in the post, the pylorus region in the duodenal bulb, what I do is I put the Ovisco clip and then completely secure it and snare on top and send it for histopathology. I also evaluate using the scan, the rotatate scan, PET CT. So we just evaluate.
But you have to be very careful. These patients post-operatively, after a few days, they may develop perforation. You have to be very careful.
Not with the Ovisco, sir. Ovisco tightly closes. Ovisco does not produce a problem, sir. So far, all the cases that we did, we had no complications.
But the only problem with Ovasco is deploying Ovasco in duodenum is sometimes very tricky.
Yeah.
Because of the lack of space. So it is not all that very easy.
Yeah, I agree with you. It's not straightforward.
Duodenum is a very the space around to which you are working on is also very limiting space. So
We
it is
saw workshops. Neuhaus had so much of difficulty he could not deploy in the post first bulbar duodenum.
Catchers, it is okay, but to deploy it in a duodenum is difficult. It's not as easy as stomach or in the esophagus.
I have done at least 3 patients, and this coming week I have 1 more patient coming.
Dr. Paidiyappan, you have to answer Dr. Jayanti. Is it because of increased use of PPI?
No, increased use of PPI because atrophic gastritis related increase in the neuroendocrine tumors of one in stomach, madam. They're all small and they're all multiple. Type 1 gastric neuroendocrine tumors are common in use of PPI. Where there's atrophic gastritis, decrease in acid secretion, so secondary rise in gastrin leading to multiple small nodules where the prognosis is good. We can observe them even clinically and endoscopically. No need for any aggressive management. But that comes in the bracket of type 1 gastric NET.
But you have to stop PPI, no?
Yes, there's a preceding factor, as you said. But here in Zollinger-Ellison syndrome, these patients, though they have been resected, the trophic factor is there. The thickened stomach is still existing. So the literature recommends that we have to continue with PPI. Though the primary and the node has been resected, PPI has to be continued.
And even for chromogranin evaluation, you have to stop PPI for 30 days before you can do chromogranin. Otherwise, you get false.
A small correction, sir. I think it is 7 days, sir. For 7 days.
7 days is what is recommended. Some authorities, even say 30 days. So much of weight has to be there before you can do chromogranin. If it is high, then it can be falsely high while on PPIs.
So that's why another doubt. Yeah.
Palni, I think we are overshooting time, and maybe we should close the session. And
dinner is waiting at respective houses now.
yes, sir.
Secretary regrets to offer dinner now today because it is a webinar.
Cocktail, Subal. Cocktail.
So you can just raise the post now.
Sooner we'll be having. We can arrange dinner at their places.
No, you can serve. Ubal, door delivery man.
No. You put a bill and pay the bill to the
the richest man is TSC, so send him.
Yes.
So Dr. Bala sir is there. Before closing, there is one important thing I missed out in that report. So the journal, there is some setback from the ISG side because we requested the national body to allow a journal, but from their point of view, there is some hesitancy using a TNISG logo on TNISG because they feel that if you start a state chapter to allow a journal, every state chapter will allow. So we agreed for their things. At the same, also agreed that a group of members can start the journal. At point of time, I approached Dr. Bala sir, who is both the patron as well as there is a big Tamil Nadu Gastroenterology Trust, which is a big brother of TNISG. So there is no hesitancy in agreeing. The journal will come in the name of. Actually, I have a slide putting a Gastroenterology Trust logo on the thing. I cannot able to display it. So the journal will be under the banner of Tamil Nadu Gastroenterology Trust, even though it is a TNISG journal. I hope all the members. I already agree. Written the letter to all the executive members. They are agreeing for that, and even the trust members agreeing for that. So just under TNIG, I think it is a setup. There isn't any hesitancy, and
the journal will not be in the name of TNISG. So it will be
under Chandabhai. Am I audible? Yeah. The parent body of ISG refused to give permission.
Okay.
That you should not use Indian Society of Gastroenterology or Tamil Nadu chapter logo. So Dr. Ramakrishna suggested even before they could refuse, in that case, can we go ahead with the trust? Okay. So the option what they gave, you can go ahead with the journal, provided you don't use the ISG or the logo of Tamil Nadu chapter. So we got this already. Tamil Nadu Gastroenterology Trust is existing for the past, say about 15 or 15, 16 years. Then Dr. Ramakrishna's opinion was gladly taken up. I spoke to all the trustees. Everybody said, okay. So we went ahead, and the first check of 1,88,800 was given from the trust. So with all your cooperation, I think we should be able to do well, Chandabhai. And the owner of the trust, you'll be happy to know Dr. K.R. Palaniswamy is going to be the owner. They are asking for who is the owner. Call them.
So that is, the journal name is called as Tamil Nadu.
No, Tamil Nadu, nothing. The journal name is GHEP, Gastroenterology, Hepatology, Endoscopy Practice. That is the name incorporated by Dr. B.S. Ramakrishna. So, lower down, the Tamil Nadu Gastroenterology Trust logo will come. Tamil Nadu chapter has nothing to do with that, because now that throughout India people are watching, let them not go ahead with an idea that Tamil Nadu Gastroenterology chapter is organizing a journal. The answer is no. We abide by the instruction given by the parent body. Am I clear, Chandabhai?
Yeah, I think I am clear, because they should not be thinking that we have become kind of the
national body.
Despite their denial, we are proceeding, and they should not feel like that. So you have totally changed the name of the journal.
That is, they are actually agreed for the members or group of members can start the journal, only don't use that. So in that thing only we started
use the logos of ISG, Tamil Nadu ISG.
Will not be there.
Yeah,
will not be there.
Yes. And we don't want, the BSR sir wanted no use of regional like Tamil Nadu, because basic our aim is to have a journal which is going to be indexed. So what he feels is, if it is something is a regional name, the indexing will be a little issue, so that it is a broad name, so that it is like a general journal, so that anybody can be published. And that's the reason that we didn't put any regional terminology in that journal name.
I think it's better you have one more round of talk with the officials, because like Indo-China agreements, it takes many rounds to convince them. Actually, they will not agree once because it's a prestige issue for them. Another thing is, we are very happy that such journal is coming after Madara Gopal's. He is a man who I remember Jayanti Malinti Madam is just laughing. When I was in this peripheral hospital, Anna used to bring bulletins. Madam, is it correct?
Correct.
Bulletins I used to read many things from that bulletins. After his death, that bulletin also died, finished. At least you are bringing in something which, in his, remembrance. It's commendable, actually. But I feel you should talk to the higher authorities.
No,
because if you have the emblem, it will be indexed nicely. Without emblem, indexing will be very difficult, actually. Indexing is very important.
No. TM, already we have the senior most editor in Tamil Nadu. The person who worked as an editor in IAG, Dr. B.S. Ramakrishna. We are going ahead with his instruction, his idea. Behind the screen, we may do 101 things. On the screen, now the ball is in his court. Every day almost I call him, the ball is in your court. Whatever you want, we have done it. And please make sure, let me make it very crystal clear, we are not doing anything against the IAG parent body. And we are getting the concurrence from those people, then we are going ahead. You got it, Raja? So, because now that not only Tamil Nadu is listening, the whole of India is listening to this conference, let them not go ahead.
That is the advantage of Zoom meetings.
No. Okay, Chandabhai?
Sir, I'll take permission to leave, sir, because I have a call. So bye and all the best. Thank you so much to Tamil Nadu.
Thanks for your timing.
Thank you to give opportunity, Gopal.
Thank you, everyone. Thank you so much.
Thank you, sir.
Thank you, Malti. Thank you, Gopal.
Thank you, TNC. Thank you, Dr. KRP. Thank you, Gopal.
Thank you, madam.
Big thank you to you.
Paul, 185 minutes non-stop scientific program. Hats off to you, man. You did very well. Keep doing it.
Thank you, sir. Thank you, sir.
Ubal, congratulations. Wonderful evening. We learned quite a bit. Thank you.
Thank you, sir. Thank you, everyone.
Thank you, everybody.
Very nice, Ubal. Thank you, Dr. Bala. Bye.
Thank you, sir.
Thank you, madam. Bye-bye.